Going market.
Carol, can you confirm you can hear us?
It's people training.
Yeah.
Or Kurt?
This is Ashley. I can hear you.
Thank you.
Kurt's here.
The guy for the right.
All right. It sounds like everybody can still hear me, correct?
I still hear you, Jenna.
Thank you.
Loud and clear.
All right. Go ahead, Tom.
I think we're ready to fire away.
Very good. Good afternoon. It is 2 o'clock in the east and 1 o'clock in the west, and this is the time and place assigned for the rules hearing for the South Dakota Board of Pharmacy. I'm Tom Nelson. I'm the vice president of the board and will act as the chair for today and chair for the public rules hearing. I'll call this meeting to order for the express purpose of holding a rules hearing pursuant to South Dakota Codified Laws, Chapter 1-26. And I will begin by reading the mission of the board. The mission of the South Dakota Board of Pharmacy is to protect and promote the health and safety of the public by supporting pharmacists and pursuing the highest quality pharmaceutical care through education, communication, licensing, legislation, regulation, and enforcement. The board wishes to promulgate rules affecting the practice of pharmacy. I will be acting as chair as well as hearing officer. You already heard that part. For those of you on the phone or on Zoom, please keep your microphones on mute until you are speaking. Reminder to everyone that when you bring to speak, please state your name, affiliation, and your comments. During roll call, please introduce yourself with your name and affiliation, and also state if you plan to speak during the public comment time. Beth, please call the roll.
Claire Rambeau,
Here.
Hanson,
Here.
Kramer. Here. Nelson.
Here,
Rising.
here.
Here.
Mr. Chair, quorum.
Thank you. First of all, we need to approve today's agenda. Before we do that, one little piece of housekeeping since we have people on Zoom, as we go through things that require a vote by the board, I will ask for motion and second, and then if there are any objections to the motion. If there are no objections, we will declare it passed. If there are objections, we will take a roll call. So for today's agenda, this meeting for the purpose of hearing comments on the proposed rules and to finalize and approve the rules of Article 20, semicolon 51 after changes are made. I will then entertain a motion to approve the agenda.
So moved.
Is there a second?
Second.
Motion by Gary and second by Shane to approve the agenda. Is there discussion on the motion? Hearing none, is there any objection to the motion? Hearing none, the motion is passed and the agenda is approved. For those in the rooms, as we will begin introduction. During the introductions again, please introduce yourself. If you are representing any organization and if you have any comments on the proposed rule. Each commenter will have approximately 5 minutes to speak when we move to the public comment period. For those of you on Zoom or on the phone, please introduce yourself and tell us who you are representing and if you plan to comment during the rules portion of the hearing. Then please assist and call out those who are on the call, please.
Okay. Chelsea Conway.
Hello, Chelsea Conway, current president of the South Dakota Farmers Association. I believe we submitted our comments in writing. Thank you.
Sarah Cronin. We will come back to her. Emily Van Klompenberg.
Hello, good afternoon. Emily Van Klompenberg. I teach law at SDSU. I submitted comments via writing and I do not have anything additional to add. Thank you.
Tracy Carlson.
Tracy Carlson, South Dakota Department of Corrections Pharmacy Manager. I do have one comment if motion is discussed.
Thank you. Noted. Amanda Bacon.
Hi, good afternoon. Amanda Bacon, Executive Director of the South Dakota Pharmacists Association. As Chelsea indicated, we did submit written comments. I believe also that Jeremy Daniel is in the room and will probably be more efficient at inserting any additional comments or answering questions than me on Zoom.
Thank you. Tyler SMC.
Good afternoon. This is Tyler Turek, Sanford Medical Center here in Sioux Falls. On my way to be there in person.
Awesome. Carol Smith. Oh, she popped off and on of mute. We can circle back. Carol is one of the other inspectors, for those of you who don't know. Alyssa Howard.
Good afternoon, Alyssa Howard or Allie Howard, representing Sanford, and also past president of SDSHP in case Ryan is not in the room. I am also on my way to be there in person.
And then David McVeigh. He has not jumped off. Right, we can check back to any. Oh,
Jenna,
yes.
Strangely, I was on a Teams link that David was on and I couldn't hear. So maybe it was just a strange IT thing.
I have seen it.
I'm here. I just couldn't find the mute button. Sorry.
Perfect. Please state your name, who you're with, if you intend to comment.
David McVeigh, board counsel for the Board of Pharmacy.
Thank you. And then Sarah Cronin. We'll just circle back to the one I didn't have. All right, go for it.
In the room now?
No, in the room, yes, please.
Good afternoon, Michelle Ite here representing Walgreens and Thank
Holly Hanman, I'm a P4 student on rotation with the board, and I do not intend to comment.
Jessica Strobel, Louis Strug. I do have a verbal comment I would like to add at this time, so I did not get my written comments in.
Lon Van Rostein, South Dakota Board of Pharmacy Senior Secretary. I will not comment.
Ryan Wabright, Assistant Vice President of Hospital Pharmacy, representing Avera, and I have submitted written comments already.
Jen Birch, having the pharmacy purchasing manager with Avera, and available for questions if there's any questions on the written comments.
Nick Roby, I'm a P4 student with Dr. Jeremy Daniel. Not intended.
Jeremy Daniel, psych pharmacist at Avera and also the vice president of SDPHA, and Amanda's making me comment. So I would probably have verbal comments. Because I just can't stop myself.
Welcome everybody in the room and online. Again, a reminder that when we get to the comment period, we will allow everybody 5 minutes to comment or less, and keeping it equal for everyone. And Beth will try to keep track of all of that. At this time, it would be appropriate. We have this packet, which is our proposed rules that I have seen and watched Tyler work diligently on, and they've gone through the rigors, but at this time it would be appropriate to move for the board to move the passage of this packet. We will get a motion and a second, then we will go into discussion and make any amendments, changes, or whatever we want to do at that point. The board is free at that time, and we'll receive comment at that period as well.
And move to accept the packet.
Second.
Motion and second, motion by Shane, second by Sherry to accept the packet as presented. Discussion on the packet of rules. Tyler.
Yes, so I will start with the process. The rules promulgation process governed by South Dakota Codified Law 126-1 through 126-13.1 inclusive and 126-38. Today, we are meeting to discuss the rules governing pharmacy practice and Articles 2051. Before we do that, I will tell you that these draft rules have been sent to the major stakeholders for comment. Formal rules review comment period was closed on June 15th. We sent notice of rules hearing and the most recent draft to our listserv and other stakeholders, and we posted them on the board's website, boards and commissions website, and the LRC rules website after the rules package was approved by the Department of Health for promulgation of rules. The fiscal note has been approved by the Bureau of Finance and Management. There is no fiscal change due to these rule proposals. The rules have been sent and reviewed by the Legislative Research Council, also known as LRC from here on out, and suggestions for changes in form and style have been received and incorporated. The notice of the hearing was placed in the Aberdeen American News, the Sioux Falls Argus Leader, and the Black Hills Pioneer on May 28th of 2026. For copies of the notices, please contact our office. At this time, I will discuss each of the changes to each of the chapters. Due to some of the LRC changes to sections and additions of other sections needed for style and form, page numbers may not align with the rules that were posted online. Any of the questions on where we are in the packet, please let us know and we'll point you to the right direction. Nothing has been removed from the original packet. 2051-02, internship requirements. In this chapter, there was change to silent forms in sections 10, 11, and 14. None of these changes have any significant impact on the rules. We are adding a new section 18, which includes disciplinary action that may be taken by the board against an intern, as these were previously not spelled out. In section 4, there was a plan to update style and form. However, it is pointed out by LRC that there are some concerns, as there does not appear to be any rule-making authority in statute around interns. Therefore, we should pull that section about their, I should say, in law about their registration. and the concerns around that. So therefore, it was recommended from LRC that we pull section 4 out of the packet at this time to continue with the remainder of the rules.
So it's the first paragraph is what you want?
No, both.
Oh, 4 is the
Yeah,
whole
yeah,
thing. Thank you for the clarification.
Take that page out when we. What we will do. 205105 restricted.
Question.
Yes.
Sorry for a minute. Do you want to do this now?
And
just go with it, or you have that as
I
you have a
it
list of
scripted
things?
that, yeah,
Okay,
yeah,
very good.
the end.
Thank you.
If you so wish.
Oh, no, sir.
205105 restricted professional practice. This chapter was largely clarity changes to simplify the rules by going with the prescription process and moving away from sections on legend drugs, controlled schedule 3s and 4s, and controlled schedule 2 drugs. These new sections are how a prescription may be received by a pharmacy and the filling and refilling of the drugs. This was an LRC recommendation to help clean up duplicative language in the sections in the various parts of the chapter. Section 00 defines a prescription to be the same as a prescription drug order in statute as well. And in section 21, we made a numbered list of the requirements to make it clearer when saying what is required on a prescription label. Chapter 205106, Pharmacy Practice and Licensure. In this chapter, pharmacy registration was changed to license, as we missed that one last year. And the law implemented sites were amended due to the law change with Senate Bill 14. Section 6 was added. The licensure fees are non-refundable. Section 2 will be repealed as it's duplicative to statute. Section 2.01 had the duplicative section of defining a pharmacist in charge out of statute and in this section, so that was removed. Sections 4 and 9 were repealed as they again duplicated law and therefore are no longer needed. Lastly, section 10 had a law implemented change and removed the repealed 2051-06-04 text. Chapter. Oh,
I can't keep up. So just let me get through.
Hi, Sanford.
Next year. Chose not to comment.
So, all right. In section 2051 or chapter, I'm sorry, 2051-13 special restrictions. Section 6 is included in this packet for style and form changes. Added to this chapter were new sections on the remote drop site. This is a new section due to passing Senate Bill 14, which has allowed us to promulgate rules. I will read those sections since they are new. LRC has made recommendations since the first submission on wording and ordering of the sections. So you will note the changes in the sections when I read those. However, the changes were not substantial to that change. So this, the new one shall read 2051-1307 remote drop site
Hold on a
designation
second.
ownership.
Hold on, let me get them.
Oh, you're in the old packet.
I'm in the packet. that was
Yeah,
sent.
this is the old one. Yeah, our new one with LRC changes.
Okay.
Sorry. Sorry, we have a million documents here. So it's going to be those. That's what previously was. It was actually. It's this one. It was previously this one. We'll change it to the other. Yeah. LRC wanted us to change the numbering. So they've changed the numbering and then they changed the title over here.
Remote drop site identification. So this is what we're working on.
This is, yeah, some of the changes that we will change the numbering. $32. Previously, this in your packet, 2051.13.05.01. It has been changed by LRC to 2051.13.07, remote drop site designation ownership. A licensed pharmacy may designate a remote drop site where a patient or a designated person may pick up a dispensed prescription. The pharmacy utilizing the site retains ownership of any prescription packages deposited at the site until received by the patient or the designated person. And you will see the general authority and law implemented below. Section 2051.13.08 previously was 2051.13.05, 03, I believe. Sorry. 03 is now 2051.13.08. Remote drop site board approval. A licensed pharmacy may obtain approval from the State Board of Pharmacy before utilizing a remote drop site. To obtain approval, the pharmacist in charge shall submit the following to the board. 1, the name, address, and license number of the pharmacy. 2, the name, and address of the remote drop site. 3, the policies and procedures for the remote drop site. And 4, security measures for the site, including an image of the locked cabinet. The pharmacist in charge must report to the board any changes to an approved remote drop site regarding changes to policies and procedures or the security measures of the remote drop site. Proposed changes to an approved remote drop site must be approved by the board prior to implementation. General authority and law implemented below. Section 2051.13.09, remote drop site requirements. Previously 2051.13.05, I think it was 02, yeah, 02. Pardon, 02. If a licensed pharmacy utilizes a remote drop site, the pharmacist in charge must ensure the following remote drop site requirements are met. 1, the remote drop site has a locked cabinet for storage of prescription packages. 2, access to the locked cabinet is limited to trained designated staff. 3, prescription packages are placed in the locked cabinet immediately upon delivery to the remote drop site. 4, only the minimum information needed to identify the patient is listed on the outside packaging. If a designated person is to pick up the prescription, the person's name is also listed on the outside packaging. 5, the identity of the patient or designated person is picking up the prescription package is documented on the prescription package log. 6, the person picking up the prescription package signs the prescription package log. Tongue twister there. 7, a designated staff member inventories the prescription packages at least weekly and provides a list of unclaimed prescription packages to the pharmacy staff. 8, a licensed or registered pharmacy staff member inspects the remote drop site for compliance at least quarterly. And 9, a licensed pharmacist inspects the remote drop site for compliance at least annually.
May I interrupt, please?
Yes.
The board members are looking at the original version. The adjusted version is on the screen. Thank you.
2051.13.10, remote drop site record keeping. A licensed pharmacy utilizing a remote drop site must maintain the following records in the pharmacy. 1, a list of all staff at the remote drop site who have been trained and have access to prescription packages. 2, a list of all prescription packages delivered to the remote drop site. And 3, documentation of required inspections. These records must be retained for at least 2 years. And lastly, in this chapter, section 2051.13.11, remote drop site, adverse issues and investigation, suspension. The State Board of Pharmacy may inspect each remote drop site. Upon notification of any adverse issues at a remote drop site, the board shall investigate the reported issue. Upon investigation, if the board determines the remote drop site is not being maintained as approved, the board must notify the pharmacist in charge in writing that the remote drop site approval is suspended pending full review by the board at the next regularly scheduled meeting. Okay. The next chapter, 2051-14, General Administration. In section 1, adding the pharmacist license renewal fee is non-refundable. And in this chapter, we have added operational waivers section. The catch lines for these sections have been modified by LRC to further outline what is needed in each section. This again is new rule concept, so we will read each of these. 2051-1405, administrative rule waiver or modification, request, prohibitions, board approval, notification. The State Board of Pharmacy may grant a waiver to modify or waive the requirements of this article if the waiver improves the quality of or access to pharmacy services. The board may not grant a waiver for licensure, registration, education, or examination requirements. A request for a waiver must be presented to the board on a form provided by the board and outlined in Administrative Rules of South Dakota 2051-1406. All waiver requests on behalf of a pharmacy must be submitted by the pharmacist in charge. The board shall consider the waiver request at its next available regularly scheduled meeting and may approve the waiver if 1. The waiver will improve the quality of or access to pharmacy services. 2. The waiver will not adversely affect directly or indirectly the health, safety, or well-being of the public. And 3. The practices under the waiver are equivalent or superior to those prescribed by the rule being waived or modified. The board shall deny any waiver if the board determines the above requirements have not been met. If a waiver is granted, the board shall provide the licensee or pharmacist in charge with written notice. The notice must be kept in the licensed pharmacy or practice location and be available for review during any inspection by the board. New section 2051-1406, waiver application requirements. A licensee or pharmacist in charge requesting a waiver shall submit an application on a form provided by the State Board of Pharmacy. The application shall include the following information. 1. The license number of the licensee responsible for overseeing the waiver. 2. The specific location where the waiver is to be implemented. 3. The reason for the waiver request. 4. A description of the process or practice that is being implemented at the location. 5. The rule that needs to be waived or modified to improve quality or access through the new process or practice. 6. A description of how the process is to be modified to ensure patients the health, safety, and well-being of the public is not compromised. And 7. The proposed timeframe for which the waiver is requested. New section 2051-1407, granted waiver, annual review, adverse issue, suspension, and review. The board shall review each waiver at least annually. Upon notification by the State Board of Pharmacy of any adverse issue resulting from the waiver, the board shall notify the licensee or pharmacist in charge in writing that the waiver is suspended pending full review by the board at the next available regularly scheduled meeting. During the suspension, the licensee or pharmacist in charge must ensure compliance with rules in this chapter regarding any rule that was waived, including any rule that was waived. That is the end of that section. So we go to 2051-15, pharmacies and hospitals, nursing facilities, or related facilities. Section 2051-1502 is redundant as the pharmacist in charge is needed to operate a and get a license in a pharmacy, therefore it was repealed. Section 10 added that the fees are non-refundable. Section 12 modified to clarify that expectations of drugs stored outside of the pharmacy in a hospital, nursing facility, or other related facility. Section 13 is modified to allow for a licensed practical nurse to go into a pharmacy after hours. Law implemented changes due to Senate Bill 14 and a new addition of the Section 2051-1518, storage of patients' own medications, which we will read here. New Section 2051-1518.
Hold up, you can get there.
Storage of a patient's own medication. The pharmacist in charge of a pharmacy in a hospital, nursing facility, hospice program, or related facility shall have a policy and procedure in place regarding medications brought into the facility by a patient. For patients' own medications that are controlled substances, the policy must state that an inventory is taken and a physical count of each controlled medication is included. The medications must be stored in a manner that prevents unintended access by the patient and others, harm, theft, or diversion. The patient's health record must contain documentation that the patient's home medications are being stored. All right, Chapter 2051-17, Automated Mechanical Distribution and Dispensing Devices. There was law implemented changes throughout due to Senate Bill 14, and LRC style and form was completed in this chapter. Chapter 2051-19, Continuing Education. We repealed the duplicative section of 02, defining an active pharmacist. Chapter 2051-20, Computer Pharmacy. There was law and rule citation changes due to some repealing of previous sections and changing law with Senate Bill 14. Chapter 2051-21, Unit Dose Systems. LRC style and form changes were completed, along with law implemented changes. We also have made an update to the type of supervision by a pharmacist in section 2051-21-01.01. 2051-22, Support Personnel. LRC style and form changes and updates to the law implemented were done there.
Hold on. Where are you at?
27. 2051-27, non-resident pharmacy registration. Section 2, changes to citing of the laws due to the Senate Bill 14. And in Section 3, added the fees are non-refundable. Section 4 removes the duplicative parts that are already in law. And then we added law implemented to our that section as well. 2051-28, Section 02.01. This is the same issue LRC has brought up as in years past, the ability of interns to immunize. With that, we will remove Section 02.01 from the updated packet. In Section 02.02, the supervision of a pharmacist has been updated for the technician immunization for consistent wording, and then we updated the law implementing. Chapter 2051-29, Registered Pharmacy Technicians. LRC changes in style and form were made throughout the chapter. Section 07 specifies, previously we had specified exact things on an application. It is now been removed and changed to a form approved by the board, therefore giving us more flexibility. We determined that something needs to be added or subtracted from an application. And then Section 12, that the fees that are paid to the board are non-refundable. Chapter 2051-30, Telepharmacy. Sections 2 and 5 were style and form changes from LRC, along with making the fees paid non-refundable. Section 3 Changes were made to the law citation due to Senate Bill 14. And lastly, Section 18 was removed as it's duplicative. And lastly, the final chapter of this packet is 2051-34. The entire chapter has been recommended to be repealed due to this South Dakota codified law process of contested case hearings. And that is the summary of everything. So I will now turn it back over to you.
Thank you, Tyler. Well done.
I don't know. It's a lot of time.
We'll now move to the comments section of the hearing. Written comments were due to the board office by June 15th. We have comments from LRC, which are form and style changes, and 2 from other individuals that have been provided to the board via U.S. mail and email. Tyler, do you want to please read and address the LRC comments?
Yes. So the LRC comments, if we, obviously, they sent the packet back to us with the style informed corrections. In addition to those corrections that were sent to us, these are the issues that they have addressed that they want to bring up to IRRC. The first bullet, the notice of public hearing does not include a reason for adopting the proposed rules. The second bullet, section 2051-0204, as I discussed when we went through this process, that LRC had asked, has questioned whether there is actually law authority for us to have the registration the way it is. Therefore, we should revert back before doing rules to actually having a law. Section 2051, 280201, same as in previous years. As you can see, May of 2024, interns and the ability to immunize. So we need to update our laws around interns and their abilities to do things before we can make the modification. Those 2 sections are already in law or in rule currently, so it was recommended that we revert those out of this section. The notice of public hearing. Let's see here. So the public of notice discussion was had with LRC. It was under the understanding by myself when completing the form, which is form notice of public hearing, that when completing the form, that there is a reason and effect, and those being one and the same in this packet, I did mistakenly only use the word effect instead of reason and effect. And I will, from now on going forward, always state both separate. And the reason LRC is calling it out is because in South Dakota Codified Law 126.4.1, those are outlined as 2 separate items instead of one and the same. And then, like we had said, we agree to remove the 2 sections to LRC until statute can be done on interns. And then lastly, Form 5, which is the fiscal note, it was stated that there is no implementation fees. LRC just wanted us to also say that there is no fiscal changes ongoing. So that form has been modified and approved as such. That is all that LRC had to offer for us. Therefore, with that, there's no talking with LRC, there's no need for an appeal letter. I will just, the only thing that'll be addressed at that meeting is that if they see the notice of public hearing as acceptable, we'll be good.
Okay. Very good. Thank you, Tyler. Melissa, I guess it's your turn to read the comment received in the office. Written comments, correct?
Yes. All right, well, we received several written comments, so I'm going to read all these in full. First is Good afternoon. I'm going to be unavailable to give in-person comments regarding the newly proposed rule changes, but did have one that I would like considered. Chapter 2051-15, Section 18. I would like to request a modification or clarification for the last sentence of the first paragraph, which is the patient's health record must contain documentation, including medications that are being stored. With the current wording, it appears that each individual medication that is being stored in the facility must be documented within the patient's chart. If I'm misinterpreting the intent, then I think having the wording changed would be a good modification. If that was the true intent, this could lead to a very cumbersome process for many facilities. We often have patients arrive at our facility with an entire tote, box, bag, basket of medications, including over-the-counters, herbals, prescriptions, etc. Would it be possible to only require documentation that medications are being stored in the facility? The patient's health record must contain documentation, including that medications are being stored. Could this be considered or revised so that only prescription medications need to be individually listed in the record? Or maybe even that the only specifically listed medications would be controlled substances and the quantity being stored, which would help with the final sentence in the section as well. I fail to see the benefit to listing every single product that a patient brings in without us asking them to do so. We are already documenting in our records that the patient has medications in the facility, so it would be easy to add the controlled substances and account of those, and I would support that requirement. Thank you for your time and consideration. Those comments were submitted by Ian Elverson, PharmD, BCPS, Pharmacy Manager at Madison Regional Health.
Wasn't that just saying that they have to document the storing of patient's medication?
Yeah.
Okay, the next public comment, written received, states, to whom it may concern, 2051-05-15.03, authorized refilling of a prescription. An important note on this section. This section must explicitly clarify that the prescription contains a total quantity that cannot be exceeded, but may be refilled up to that amount. The opening line of this section currently makes a loose assumption that a script cannot be refilled without refill stated. A prescription may not be refilled except as designated on the original prescription or as subsequently authorized by the prescriber. Example, a script written for quantity 90, taking 1 dosage unit daily, no refills. I fill a 30-day supply, quantity 30, but refills were not designated on the original prescription, creating a gray area that insurance companies, PBMs, and lawyers will point out and ruin a pharmacy or pharmacist. Language must be clear to protect the public, but the law should not put pharmacists and pharmacies at risk. Secondly, the way the subsequent section 1 is written does not make it clear that the prescription can be treated as a total quantity. Example, a script written for quantity 30, taking 1 dosage unit daily, plus 3 additional refills. If I fill for 90, the same crew, who is insurance companies, PBMs, and lawyers, will be able to use the ambiguous nature of this section to say we did not fill and refill according to providers' directions. Language must be clear to protect the public, but the law should not put pharmacists and pharmacies at risk. Thirdly, the phrase 12 months from original date of issue needs to be changed. This ambiguous timeframe also puts pharmacists and pharmacies at risk. Example, prescription written May 29th, 2026 cannot be filled on May 1st, 2027 because that would be the 13th month in the eyes of the insurance company, a PBM, or a lawyer. I believe most or all pharmacies in the state follow the board's guidance of best practice of only filling for a 12-month period, so I'm questioning why the board feels the need to specify the language to the 12-month period at all. Solutions. I will now do my best to rewrite the majority of this section using language that I believe preserves your intent but does not put pharmacists and pharmacies at risk. 2051-05-15.03, authorized filling of a prescription. A prescription may be dispensed up to the total quantity listed on the original prescription. This total quantity includes the original dispensing and any refills authorized on the original prescription or is subsequently authorized by the prescriber. Each refill must be entered on the back of the original prescription or captured electronically and must include the quantity dispensed, the date refilled, and the initials or name of the dispensing pharmacist. Any prescription renewed by the prescriber constitutes a new and separate prescription. It must be assigned a new serial number and is subject to the restrictions in this section. A prescription may be filled under the following conditions. 1. Legend non-controlled drugs may only be dispensed for the total quantity on the prescription order and not filled or refilled after X from original date of issue. And for that X, options include, by this individual, would be 16 months or less based on the pharmacist's professional judgment, or 365 days or less based on the pharmacist's professional judgment, or 8,760 hours or less based on the pharmacist's professional judgment. And this is signed regards, Austin Oyen, PharmD, Lewis Drug, pharmacist. And this is more comments from Austin Oyen, pharmacist at Lewis Drug. For 2051-05-15.03, if the prescriber is unable to be contacted to authorize refills, the pharmacist may fill up to a 30-day supply of a non-controlled legend drug, if in the professional judgment of the pharmacist, the drug is necessary to maintain the patient's health. This sentence must be an entire section in the law. This raises so many questions that it does not accomplish its goal, but rather creates many issues that primarily puts pharmacists and pharmacies at risk, but also puts the public at risk. If the prescriber is unable to be contacted to authorize refills, is this an ability issue or an actual communication issue? We can often initiate a request electronically, but we may not hear back. Is this unable? Does all available internet, phones, faxes all have to be down for unable to be applied? We can often call an on-call provider, but often a different provider. Is this considered unable to contact provider? May fill. The language in the rest of the chapter and laws typically refer to dispensing, not filling. To fill does not have definition laws that I can reference, but dispensing does have definitions associated with it. This term, therefore, also creates confusion. Up to a 30-day supply. 30-day supply is an issue as some products use discrete dosage units. Example, a box of insulin typically cannot be broken down, but may not allow for a 30-day or less dispensing. A single discrete dosage unit could theoretically last up to 125 days. Up to 30-day supply. A prescription for 2 days of antibiotic or warfarin could potentially be filled for 30 days, assuming professional discretion. This is not realistic, but the public could certainly produce pressure on a pharmacist for these expectations based on the language in this sentence. Additional questions. Whose authority or NPI is associated with said dispensing? If pharmacists, then why aren't we included on the list of providers with authority to prescribe? If providers' NPI is to be associated with the fill, what are the notification requirements? I'm sure that the pharmacy would be expected to inform provider of a dispensing that occurred under their NPI without their knowledge. This sentence does not state any notice requirements nor documentation requirements exist. Solution. Place pharmacists under the table of prescriptive authority, granting ability to prescribe non-controlled legend drugs and non-legend drugs. Nowhere in our current laws and rules is it stated who may prescribe OTC items. This should be included in law, but that is a separate tangent entirely. With pharmacists receiving prescriptive authority, the above concerns and issues are completely accounted for. Again, regards, Austin Oyen, the pharmacist, Lewis Drugs. And then lastly, to whom it may concern. I sent a few questions and concerns previously, but I also want to say some aspects of the proposed rule changes that I love. The addition of the remote drop site into the rules appears well thought out, and I'm excited about it. Thank you. Austin Oyen, PharmD, pharmacist, Lewis Drugs. Good evening. Thank you for sharing the opportunity to comment on the proposed rules that will be reviewed at the hearing this month. I took screenshots of a few of them and have a few questions, clarifications that I would like to respectfully submit for consideration. So this is, I guess there's
the image.
Yeah, so there's the image that was provided. So question 1, in the proposed rule above, would an agent of the prescriber also be a suitable person to sign a handwritten or facsimile prescription? Next image, so question 2. If this rule were to pass, would it be acceptable to delegate a portion of a monthly check to licensed clinical staff in other departments? For example, each department has licensed nurses review each entire crash cart for outdated supplies, etc., which requires breaking of the numbered seal and a complete inventory of all non-medication items, during which they review the medication tray and ensure that it is still in date and sealed. Pharmacy repeating this process on every crash cart monthly to review the medication tray would technically require a full inventory of every supply, since that's supposed to be done anytime the lock on a crash cart is broken. Would a process to what I described be permitted under the new rule, particularly if that department documents their review of the medication tray to be sealed and in date? Okay, image 3. Question 3. Would there be any consideration for allowing the record keeping for storage of a patient's own med to be maintained by pharmacy in a readily retrievable format for a certain amount of time as an alternate to documentation in the patient's health record? For example, see the attached form that we use to track patients' own controlled substances currently, which is maintained in pharmacy. We keep for 2 years on hand electronically indefinitely since it's for controlled substances. From my perspective, I think a form like this would meet the goal of proving that the medication is being stored in a manner that prevents unintended access, harm, theft, or diversion. And if a health record document is the only suitable way to document the storage, it would be an easy step to forget after using the form. And the final image, question 4. I would like to clarify that I understand correctly the addition of the word license to mean pharmacist only since technicians are registered and pharmacists are licensed. I'm wondering if it would be acceptable under this rule for a pharmacy technician to be the primary owner of a policy as long as it's approved by a licensed pharmacist is documented. For example, there are pharmacy technician coordinators at Avera that specialize in areas such as pharmacy technology, PIXIS, and controlled substance handling that, due to their job being fully focused in that area, would likely create a superior policy to a pharmacy leader whose attention isn't focused as intensely in these topics. Having a technician coordinator / specialist be the owner of a policy that goes through an approval process where it's officially approved by a pharmacist who understands state law seems as though it would be the best case scenario to me. So I was hoping to clarify that such a process would be permitted under this rule. I appreciate the thought and care that the board puts into partnering with the pharmacists across the state to provide the best care to our patients that we can. Please let me know if I can further clarify my questions and suggestions. And this was submitted by John Daniel, PharmD, Pharmacy Director of Avera Heart Hospital. Next, dear Dr. Letch, on behalf of Avera McKenna Hospital and University Health Center, we appreciate the board's thoughtful consideration of the proposed operational waiver framework contained within ARSD 2051-1405 through 2051-1407, as well as the new rules proposed for remote drop sites. We fully support the proposed rules for remote drop sites. Remote drop sites are secure non-pharmacy locations where patients can pick up their prescription medications. These sites improve patient access to prescription medications by reducing barriers related to distance and limited pharmacy hours. Regarding the proposed waiver rules, we support the board's efforts to create a regulatory pathway that promotes innovation, improves access to pharmacy services, and allows pharmacy practice to continue evolving alongside advancements in healthcare delivery, automation, technology, and workforce development. Health systems and hospital pharmacies across the country continue to face increasing operational complexity, workforce shortages, and growing demands for clinical pharmacy services. In this environment, innovative pharmacy practice models are essential to ensuring pharmacists can practice at the top of their license while maintaining safe, efficient, and patient-centered medication use systems. The proposed waiver framework represents an important opportunity to support innovative care models, including technology-assisted workflows, centralized operations, and technician-supported practice models such as Tech Check Tech, also known as TCT, where appropriate safeguards, competency validation, and quality assurance measures are in place. Importantly, we believe innovation in pharmacy practice should remain grounded in patient safety, quality outcomes, and alignment with board oversight. We are particularly supportive of the board establishing a mechanism that allows emerging and evolving pharmacy practice models to be evaluated through a structured review process rather than requiring rules change for every operational advancement. This approach creates needed flexibility while maintaining board oversight and accountability. At the same time, we respectfully offer a few questions and considerations that we believe would help strengthen implementation, clarity, consistency, and long-term success for both the board and regulated entities. Number 1, evidence standards. The proposed language requires that the practice under the waiver are equivalent or superior to those prescribed by the ruling being waived. We respectfully request additional clarification regarding the types of evidence, quality metrics, or operational safeguards the board anticipates relying upon when evaluating whether a proposed practice model meets this standard. Additional guidance regarding acceptable evidence sources, published literature, internal quality metrics, audits, competency assessments, or accreditation-based standards would help organizations develop waiver requests that align with board expectations while promoting consistency across applicants. Number 2, suspension process. We appreciate the board's commitment to maintaining oversight for approved waivers. At the same time, we respectfully request additional clarification regarding the process surrounding waiver suspension in the event of operational concerns or adverse issues. Specifically, the proposed rule mentions, upon notification of any adverse issues resulting from a waiver, the board shall notify the licensee or pharmacist in charge in writing that a waiver is suspended pending full review by the board at the next available regularly scheduled meeting. We request clarification regarding what constitutes an adverse issue, whether scope, scale, thresholds, or patient harm considerations will apply, whether corrective action pathways may be permitted prior to immediate suspension in the absence of imminent patient safety risk. For hospital and health system environments operating complex medication use systems, abrupt operational reversals may create unintended patient care and staffing challenges. A collaborative corrective action pathway may help support both safety and continuity of care. Number 3, annual review requirements. We also respectfully request additional clarification regarding ongoing reporting expectations associated with annual waiver review. Specifically, additional guidance would help ensure organizations develop appropriate monitoring and quality assurance programs that support board oversight. This would include expected reporting frequency, quality metrics, and any adverse event reporting thresholds. Establishing consistent reporting expectations may also help facilitate meaningful evaluation of innovative practice models and support data-driven regulatory decision-making over time. Overall, we believe the proposed operational waiver framework represents a positive step forward for pharmacy practice in South Dakota. The ability to thoughtfully evaluate innovative operational models through a structured oversight process creates opportunities to improve medication use systems and advance the profession of pharmacy while maintaining patient safety as the highest priority. We appreciate the board's leadership and willingness to consider regulatory approaches that allow pharmacy practice to continue evolving in response to changing healthcare needs. Thank you for your consideration and ongoing commitment to safe and effective pharmacy practice in South Dakota. Respectfully, Ryan A. Wainwright, PharmD, BCCP, Assistant Vice President, Pharmacy at Vera McKenna. Hello, please see below for my comments on the proposed rules. Overall, I appreciate the streamlining of the 2051-05 section. It removes the ambiguity between non-controlled and controlled prescriptions, thus making easier to teach. 2051-0204, 2 and 4 should both statements read a pharmacist licensure applicant. 2051-05-15, the prescription must contain, in section 4, the prescriber's signature and the date of issuance. What about telephoned in prescriptions? I acknowledge that this may be covered in 2051-05-15.02. Handwritten or facsimile prescriptions must be manually signed. For 2051-0601 and 2051-0602, both sections seem like the verbiage could be cleaned up, made more clear. 2051-0602, on a form prescribed by the board. Could this be changed to on a form provided by the board to be the same as other sections? 2051-1306-6, should this be a pharmacy staff or pharmacist? Also, should inspections be at least every 90 days or every quarter? 2051-1305.02, this section states quarterly visits. I guess I'm just asking for consistency in language in our rule. 2051-1406, a licensee or pharmacist in charge. 2051-1405 states that the waiver has to be submitted by PIP. 2051-05-20, this section is being repealed and most information is being transcribed to different new sections. However, I can't find where the prescriptions must be filed and retained for 2 years from the last dispensing date. The rule calls out how long to retain records in many other places, so don't want to miss this. Thanks. I'm Emily Van Kloppenberg, PharmD, Assistant Professor of Pharmacy Practice, College of Pharmacy and Allied Health Professions, Avera Health and Science. Good evening. Thank you for the opportunity to submit comments. You will find the written comments from SDPHA attached. I plan to participate in the hearing via Zoom, and Jeremy Daniel will attend in person. Please let us know if there's anything else you would like from us prior. Hopefully you're not seeing this until Monday, but in the event you see it before, have a wonderful weekend. Amanda Bacon, Executive Director, SDPHA. Dear members of the board, on behalf of the South Dakota Pharmacists Association, SDPHA, thank you for the opportunity to provide comments on the adoption and amendment of proposed administrative rules in South Dakota numbered 2051-02, 2051-05, 2051-06, 2051-13, 2051-14, 2051-15, 2051-17, 2051-19, 2051-20, 2051-21, 2051-22, 2051-27, 2051-28, 2051-29, 2051-30, and 2051-34. SDPHA appreciates the board's ongoing work to modernize pharmacy regulations, improve clarity, and support the safe delivery of pharmacy services across South Dakota. The association generally supports the direction of the proposed rules package and respectfully offers the following comments for consideration. Prescriber registration number requirement. That's in 2051-05-15. The last sentence of the proposed rule states that controlled substance prescriptions must include the prescriber's federal registration number. SDPHA requests clarification regarding this provision to avoid confusion concerning which identifier is required. Specifically, identifying the DEA registration number for controlled substance prescriptions would help ensure consistent interpretation and implementation by pharmacists, prescribers, and healthcare organizations. Number 2, remote drop site employee list, 2051-1305.021. The proposed rule would require pharmacies to maintain a list of all staff at a remote drop site who have been trained and have access to prescription packages. SDPHA supports the board's goal of ensuring accountability and security at remote drop sites. However, in many settings, employee changes may occur frequently, making it difficult for a pharmacy to maintain an accurate and continuously updated list of individual employees. We respectfully recommend modifying the rule to allow documentation of authorized positions, job classifications, or designated site personnel maintained by the host organization rather than requiring pharmacies to maintain a current roster of individual employees. This approach would preserve accountability while creating a more practical compliance framework. 3, storage of drugs located outside the pharmacy, 2051-1512. The proposed rule requires maintenance of records related to medications stored outside the pharmacy, including monthly checks of all storage locations and documentation regarding employee access. SDPHA supports appropriate oversight of medications stored outside the pharmacy department. However, in larger hospitals, healthcare systems, and long-term care settings, medications may be stored in numerous approved locations. Monthly inspection requirements and maintenance of employee-specific access lists may create significant administrative burdens without necessarily improving patient safety. We recommend consideration of a more flexible approach that allows facilities to document access by authorized role, department, or job classification rather than by individual employee name. This would better align with existing healthcare operational practices while maintaining appropriate accountability. And this would be number 4, automated mechanical distribution devices, 2051-1701.02. The proposed rule requires pharmacist review of a prescription drug order before the first dose may be removed from an automated mechanical distribution device while allowing limited exceptions for emergency situations. SDPHA supports pharmacist review as an important patient safety measure. However, there are circumstances in hospitals and procedural settings where immediate medication administration is necessary and a licensed prescriber is physically present directing patient care. In these situations, delays associated with obtaining pharmacist review may adversely affect patient care. SDPHA recommends the board consider expanding the exception to include circumstance in which immediate administration is necessary, delay could adversely affect patient care, and a licensed prescriber is present in directing the care of the patient. This recommendation would preserve the important role of pharmacist review while recognizing real-world clinical workflows and ensuring timely access to medications when patient care requires immediate intervention. SDPHA appreciates the board's thoughtful consideration of these comments and its continued commitment to protecting public health while supporting patient access to pharmacy services throughout South Dakota. We look forward to continued collaboration and would be pleased to discuss any of these recommendations further. Respectfully submitted, Amanda Bacon, Executive Director, South Dakota Pharmacists Association. And the final written comment we received. Good morning. For your consideration. Page 11, 2051-0515. Change the prescription must contain the full legal name to just full name as before. In many instances, full legal name is not used. This would be hard to police enforce, but insurances might use as a reason to claw back. Page 14, 2051-0515.03. Under a prescription may be filled under the following conditions. Legend non-controlled drugs may only be refilled for the total quantity on the prescription order and not filled or refilled after 12 months from original date of issue. If the prescriber is unable to be contacted to authorize refills, the pharmacist may fill up to a 30-day supply of a non-controlled legend drug if, in the professional judgment of the pharmacist, the drug is necessary to maintain the patient's health. This is great, but what is the process for this? What documentation is needed? Is it okay to run under the same doc? It would be helpful to know what the process is. Page 14, 2051-0515.03, under same section. Schedule 3 and 4 controlled substances may only be refilled as authorized on the prescription up to 5 times within 6 months after the date of issue. The partial dispensing of refills may not exceed the total amount authorized on the prescription. To clarify, could this be? The partial dispensing of refills may not exceed the total quantity authorized on the prescription. The wording before sounds like can exceed number of refills. Thank you, Austin R. Block, Page Pharmacy in South Dakota.
Thank you, Melissa. Well done.
Oh.
More?
There was one.
Sorry, one more. Sorry. One more. Thanks for notice. Large packet of proposed rules, good for you, a lot of work. My only small suggestion is on page 46, 2051-1513 to add, or licensed practical nurse, licensed pursuant to South Dakota Codified Law, Chapter 36-9, designated, but not a big deal if not included. Thanks, Linda. P.S. Board of Nursing is also promulgating a few rule changes, and she has the location. And that was actually from Linda Young, Executive Director of the South Dakota Board of Nursing.
Now is that it?
Drink of water.
Thank you, Melissa. We'll now go to first public comment of those in the room and then those on Zoom. I think you indicated if you were we're going to make comments. Beth and Jenna are going to call on them individually. That's fine. You each have 5 minutes. Again, we won't be discussing the comments until item G on the agenda. So proceed, however.
Do you want to do online first? Okay, we'll move to those who online had indicated they have a comment. And I think the only one I made note of is Tracy Carlson. So once you start, you have 5 minutes to provide public comment.
Yes, I just wanted to comment on the waiver section. I think that is a great addition. I know our structure here is set up a little differently, so this would definitely assist with our processes. I would like more information regarding the suspension upon adverse notification, what that is constituted, and if there is a period of time to allow for us to pause the waiver operating system, just because we have several facilities that would need to be changed if that were to occur. That's all.
Thank you, Tracy. All right, Beth, those in the room? Those in the room can just start.
I think all of my comments have been addressed in the written comments or are close, except one. And I apologize because I think the numbering system might be different. But I have written down 2051 130501 and maybe 04 now, where it's indicated that at a remote drop site, if an intended person is allotted to pick that up, that the package has to contain a pickup person's name. And I think operationally, that would be incredibly difficult. If we get a call at the filling store to say, I'm picking up my son's prescription tomorrow, there's no way in the software to put the mom's name or vice versa. I'm picking up my mom's prescription, whatever it might be. So I'm picturing like sticky notes or handwritten notes, and I feel like that is potentially an issue. So it feels kind of clunky. You know, if there was some sort of like documentation requirement of who picks it up on the log, that makes sense to me, but to have that documented on the package itself seems to be kind of impossible. I think everything else I have will be addressed. By Jeremy?
So since you have this up, it's probably easiest, Jenna, because I just made notes of what the things are. You go up a page to 2115-1308.
Give me, yep, I'm just gonna write down this number here quick for my record for her. Quick.
Just take 5 minutes. It's okay.
Let's pause All right, you want up a page?
Yeah, to 2115-13. Specifically looking at, I think it was number 3, where again the policies and procedures for the remote drop site. I was wondering if the board had any clarification on what that is. Is it kind of the board's discretion that they just have a policy and procedure, or the policy and procedure has specific components to it? Just because, again, if it is something from a gas station where if you're just picking that up from a locked cabinet, you know, is that sufficient that it's in a locked cabinet and they can grab that? So I don't know if that's going to be a document the board creates later on, or if there are just any clarification pieces of that. Down the next page, 2115-1309, particularly subsection 4.
Getting there.
Could probably address that when you were down there. So I think, yeah, that's just the same piece that Jess talked about. So just kidding. 2115-1310. Looking specifically at 1, I think this was kind of raised within SDPHA's comments, but again, specifically a list of all staff that are at that drop site is going to be very, very challenging, especially in like the grocery store, for example, where those clerks turn over very, very quickly. So where SDPHA supported a list of types of personnel that could access, that's probably easier for a pharmacy to keep track of. Like it has to be again, certified cashier or, something else given that job site, a list of individual personnel should be a little bit challenging. In 2151-1405, I think this was within the waiver process. One of the questions that we've had, especially as a health system, is the language within the section of 2151-1405 kind of reads that it is specifically an individual pharmacy. And so one of the questions that we would have is if it is a chain of community pharmacies, or again, within Sanford Health or Avera Health, is an individual waiver required for every single site that does this piece. And so if we do have a check text system within Avera Central Pharmacies, is that appropriate to then apply to the entire Avera system, or Sanford system, or Monument system, or does each individual pharmacy have to supply that? I think also as we go down a page into 2115-1406, specifically number 2 within that section, it's again the specific location of that waiver where to be implemented. Can that be a listing of multiple locations, or is that just again one specific location per form, which would then be a lot more forms for the board. A couple more, 2151-1518. I did definitely support Ian Alberson's comments on this, where he talked about a list of medications that a patient brings in stores. Working in the inpatient psychiatry environment, where occasionally patients come in with a literal 55-gallon trash bag full of medications that may or may not even be theirs, it would be a little bit challenging to document. Now, our staff is really diligent about pulling out controlled substances and storing those separately, writing them on a bag with quantity and signing across that double seal to make sure that we are keeping those separate from other legend medications. But it would be extremely challenging, especially for that last, or within that section, documenting every single medication within the patient's health record. That's really tough. So having medications stored, as Ian suggested, would be my recommendation, just as an individual pharmacist, just to make that easier so we know that medications are stored. If we want to call that out specifically, that controlled substances have to be named by name and quantity, and that is specifically documented, I'm perfectly fine with that. But every single individual OTC or legend drug is really challenging within our system. Lastly, 2115, oops, sorry, we can go back, 1407. This was the waiver process. So
back
also,
up. What? Back up, 1407.
2051-1407, I wrote out of order.
That's okay.
This was about the annual reporting of the waivers, I believe, where again, a board will review all waivers on an annual basis. There was really nothing within that law piece about requirements to be submitted annually. So I know within Ryan's section, he mentioned, do we have to submit metrics? Are there specific things that the board wants? This specifically just kind of addresses how we can review that particular piece. So do we even have to submit anything? Does the board review those in private on an annual basis? Is that board staff, the board of pharmacy? There's maybe more clarification needed within that waiver process. But I believe I stayed under my 5, so it was fair.
Yes, you do.
They crushed it. Yeah.
Any additional comments from the room?
Nose goes?
I'm thinking.
Is that like nose goes? I was like, you think you gotta be looking at Tyler for that. Not this time. But it's all good.
A lot of extra things to think about. Well, okay, I guess I can share them. I don't know the actual rule. I think where I'm the most stuck perhaps is the medication stored outside of the pharmacy. And definitely appreciate the intention of making sure that appropriate users have access, that they're stored appropriately, that we know what's there. I'm just thinking about how I put all of that on paper at the med center, for example. Obviously, most of our products are in automated dispensing cabinets, things like that. But as we look across hospitals throughout our rural footprint, a lot of them don't have the luxury to have it in function all of the time. So I can appreciate it. I think I don't know what the solution is. Perhaps not an identified list of users. Maybe it's updated annually. I can appreciate the intention. I think that's where I'm getting stuck probably.
Is it readily retrievable?
Readily retrievable, maybe.
I think I would want to understand the intention. If all of a sudden the hospital makes a change mid-annual review process, they don't publish it on paper. I don't think that discounts the accountability that certainly that pharmacy takes to place that medication there, just because it's not on paper or that different username isn't updated. I don't think that negates the intentionality probably that went behind the actual action.
Are there any further comments that we're unaware of either in the room or online? Thank you all for your comments, your interest, and your expertise. We're going to take a break. Right? 15 minutes?
Right.
Okay.
Be back at 3:30. Thank you.
Right.
Well played. Shots
I
fired.
Just gotta keep us on track. I said at least I was here on time. I was on one.
Welcome back, everybody. For those of you that were on time.
The green and blue are not good.
At this time, we'll go into the situation, the part where the board and staff will discuss proposed changes to the proposed rules changes. And I think Jenna has the commentary or comments on the written proposals or the written comments at this time.
So as I go through, I really did try to make it as visually friendly for those who are listening and those who are here for the sections that were mentioned in the comments that were submitted. We might address the verbal ones as we go through, because some of my commentary will maybe resolve some of the verbal ones as we go through, or then some things have come up here in the room that may adjust what our response is going to be to said comment. So we'll start with the ones from Ian, if it goes here for me. So his main comment was for chapter 2051-16, and he was inquiring, similar to John Daniel's comments, similar to Jeremy's comments, regarding the feasibility of providing patient-owned medication documentation. And prior to the changes, it in fact did kind of read that including medications that are being stored was in that section, which is highlighted above in his comment. In the interim, it had been changed, given a little bit of editing, to the patient's health record must contain documentation that the patient's home medications are being stored. Sorry, I cut that off a little bit here. So truthfully, this section has already been edited to remove the ambiguity where some felt that a true inventory of every single med would need to be included. So that's where we kind of live with that. Questions?
This language was LRC basically kind of already fixed that for you guys when they had their style and form changes. I think that's livable.
Good.
It's much better, yes.
When multiple people said it and we had it already, I'm like, boom, that's great.
That the first time we got it, we were like, what do you mean? Because they did the style and form with LFC. What are they talking about? A list of medications?
Yeah. Okay, that's what I was wondering. It looked like it was pretty clear to me too.
Yeah, right.
Okay.
All right, the next set of questions are from Austin. His initial question here is on 2051, 05, 15, 03, and several of his questions are regarding this section, the refilling of a prescription. I want to just kind of highlight, Tyler did highlight this, but this whole section had significant revision, not necessarily for content. There was some content added, but more so for organization because it took up 5 to 6 sections and now it is condensed down for ease of use and ease of understanding. So some of the comments where someone may perceive that it's new because it is underlined, truthfully is just a move from a prior section. So I have referenced that as we go through, but just kind of keep that in mind. Not everything underlined is new. It might just be new to that section. So his initial question, is regarding refilling a prescription for and partial filling a prescription. So he kind of puts the piece up there, prescription may not be refilled as designated from the original prescription, and then provides an example where he's truthfully, the example is about partial filling. So we don't change any of our language to prevent partial filling, inhibit partial filling, change the total quantity that something can be partial filled. We really fall in line with how the federal government lines up with a refill versus a partial fill. So I would just recommend the language maintain as is in this case, because it really is not prohibiting any partial filling. Again, the second section was about the same, refilling of a prescription. And in this case, concern is for limitations of total quantity dispensing. And there really isn't a limit on what you can dispense as long as it is allowable in the total quantity of the prescription. We don't limit that. We also do not limit how quickly you can refill something. So if you're going to fill something to the total quantity of refills allowed, that's totally fine. And that's also supported, excuse me, I gotta go back. That functionality would be supported in our policy statement that has been available on the board website and has been in place for a while. Right. Next section, again, we're in refilling of a prescription, and the concern in here that he brought up is regarding the 12-month dating expiration date on a legend non-controlled drug. And the commentary in the comment makes it sound like it was a board best practice to do this when in fact it has been in rule historically. And so this is that case where I'm not sure if he was not aware that it was in there or just lost it in all of the editing. But here it lies in 0520 as that 12 months from original issue date, and we just essentially moved it into a different section. So it wasn't board guidance, it has been in place. You know, if there is issue with the 12-month language, we would love to hear that there's concern there, although the 6-month language is applicable to controlled substances, so it's pretty consistent with expectations for controlled substances. So he provided a kind of as Melissa went through, kind of the questions and then some solutions, but again, the solutions don't necessarily dictate any changes, and my commentary above did not dictate any changes. So I just wanted to highlight that even given his solutions, we're not going to necessarily make any changes to those sections. This section is related to commentary in, again, refilling of a prescription, where it says if the prescriber is unable to be contacted to authorize a refill, the pharmacist may refill up to a 30-day supply of non-controlled legend drug if the professional judgment of the pharmacist and the drug is necessary to maintain the patient's health. This section had a couple different people comment on it. I would like to just to say it was a newer addition to the previously written rules, I believe put in 2024. Overall, if a pharmacist is choosing to utilize that section, which does provide some level of flexibility, there is going to be some professional judgment that they have to implement if they decide to use it. So it's not an addition to the rule. It's been in there for the last 3 or 4 years already. I don't know how frequently that's utilized, but it does provide potential flexibility if needed in there. The other kind of notation that he brought up in his comment was, what provider is it supposed to be under? Well, the rule does indicate that it's a refill to a currently active script. So it's not as if you're writing a prescription as a pharmacist. So no recommendation to change at this point given. John Daniels. And I added this section above because he had just put a picture in there. So his question was inquiring if a provider's agent would be a suitable person to sign a handwritten or fax prescription. Our recommendation is to not change that. And that is just to ensure there's consistency between non-controlled and controlled drugs. I would not want someone to be able to sign off for a provider on a lisinopril, but then not on a tramadol. That creates too much back and forth and too much area for mistakes to be made. The next comment is related to storage of drugs in other areas than pharmacy. So recommendation as of my creation of this was to maintain that they're checked by pharmacy employees. And the support for that would be that there are findings continually on inspection when pharmacy is not involved in the maintenance and storage of drugs outside of the pharmacy, that there are issues with expiration dates and product integrity issues. The other issue is that if other clinical staff are maintaining drugs, sometimes pharmacy is not aware that the drugs are there. And I also find that on inspection as well. So I cannot recommend that pharmacy staff be delegating this to other clinical staff. I would have to not have any findings for that to be an option. Although I am going to make a recommendation that's a little bit different from what's here, given our conversation in the room, that we need to look at when products are stored in AMDDs in relation to products that are stored outside of an AMDD type device. So that'll be when we talk about commentary, given our conversation in here, that I think needs to be added upon further scrutiny of this section. The other section here regarding storage of patient medications, he mentioned it too. Again, no recommendation because it has already been changed. And I will tell everyone, when we put together that section for the rules as to how that section is written, it was upon and following discussion with the DEA and how they would maybe not necessarily allow, but be potentially for storage outside of the patient room given some certain circumstances. And one of them was documentation in the EHR. And then the other was kind of, as it lists in there, that, to prevent theft, diversion, harm to a patient. So that's why some of that specific language is in there. And I think the removal that we did earlier helps make people feel less like they have to put all the drugs in there. And the last thing here, I think might have just been a simple read error. So it's hard to see, but up here in the top, it says a licensed pharmacy employee. And based on his comment, it sounds like it was read as a licensed pharmacy employee. There's nothing in here that would say that a technician cannot be the owner of a policy as long as the approved, procedure is in place to have it reviewed. So I think it may be a little bit of just a read error on that. Recommend keep as written. Ryan, you're in the room. So I will preface several of Ryan's comments and Jeremy's as well, where there was inquiry and Tracy's, which was on the phone or on Zoom, regarding further detail, further clarification to be provided by the board for the operational waiver scenario and process. The issue that we're going to run into is the feasibility to provide specifics is really not there at this point. And if I provide more specifics, I'm going to potentially limit what we can do with the operational waivers. In several conversations we've had about how this can look, I think there might be a little bit of growing pains as we work through the initial ones. But some of those pieces, such as, what's going to be required, or what I highlighted there, Ryan's question was, how do I determine what's equivalent or superior to a current practice? that's probably going to be on who's presenting the waiver to show why you should be given the waiver. So that's why I can't necessarily go through and add more detail in here for those types of questions. Yes.
Question at the moment. So I guess when we had variances previously, typically reporting requirements or anything like that was just really generated with that given variance.
Correct.
Are we expecting that same?
That is the
process with the
expectation
waiver?
going forward, given what the waiver and variance is for, and given the concerns that as we go through and review it are brought up, what kind of patient safety concerns are there, quality, accessibility to care, all of those kind of things. Yes. So this section regarding the adverse issue, there is, I think Ryan had mentioned, like, what is an adverse issue? And I am open, and we can certainly have a conversation if there's a better way to state the word adverse issue. But as we tossed around the different ways you could say an adverse event, a med event, we can't say med event because potentially this could be an operational thing that is not related to a medication. So we really left it at adverse issue as the best way to fit lots of things potentially under a hat. I know that right as we kind of had this conversation, and conversation in the room, I'm going to change kind of what we had put up here. Go to the next one here. Oh, no. Okay. And I think given our conversation in here, we are going to suggest a change. If you see the red part, that's what I'm going to change here on the fly. To state, upon notification of any adverse issues at a remote drop site, the board shall investigate the reported issue. Upon investigation, if the board determines the requirements in section 2051-1205 are not upheld, then the pharmacist in charge in writing that the waiver would be suspended pending full review. So it gives that step down very similar, and what I'm holding in my hands is actually the remote drop sites one. Kind of that step down process versus like we're notified and you lose it, which is I think the concern that you guys had. So we will make that change. Does that help?
Yeah.
Okay. Any further question? Tracy, did you have any commentary on that? I know that that was a piece that you inquired about as well.
No, I think that would help with my concern there. So thank you.
Perfect. Perfect. Questions? Good. Okay. The other one regarding an annual review, again, this would be dictated in the approval that you would be issued. So I'm not going to necessarily recommend a change. It's going to be on the fly. Maybe as we get some more of these in place, if we end up delineating like patient care or operational waivers, then some of this might build in the future. But I just would like to leave it as open to opportunity as we can while maintaining safety and all those things. Emily Van Kloppenberg, I appreciate that she recognized we changed and organized some things a little bit. Thank you for that. The section in question 2051-0204 actually is being removed, which Tyler alluded to in the front, so that will just be taken out. 2051-0515 regarding the prescriber's signature. This is section 15. So the signature part on there, this is requirements of a prescription. We're going to plan to recommend a change to name, the prescriber's name on there. So Tyler will talk about that as he provides a summary. So 2051-0601 and 0602, she basically brought forward that, form provided by the board or form prescribed by the board, but one of the sections she had in questions is fully repealed, so that continuity issue should be gone. 2051-130606 is a question related to pharmacy, who should be checking medications located at a location that are starter packs. So 1306 is relation to starter packs. And upon a little bit more investigation to this, it currently says pharmacy staff. Is that correct, Tyler?
Pharmacy staff.
And that brings up a point of concern. While she alluded to in her question, should it be pharmacy staff or pharmacist? We would like recommending further conversation from the board about what this looks like as it relates to pharmacist technician oversight outside of the pharmacy. And if we should have the pharmacist checking these locations, because it does pertain to checking logs, policy and procedure, inventory, dispensing logs that are located at the starter pack site. So I think further conversation about if this should be pharmacy staff or pharmacist in this section is warranted. And I can pull that up when we do it. I didn't get it put on here. And then she also inquired about if the checks for the starter pack locations, which comes right here, 0502, is related to remote drop site, even though this number is a little bit wonky, is related to remote drop site. And so she's saying, should starter pack visits and visits to remote drop sites be the same? And the feeling is that they are not to be treated the same because starter packs are undispensed medications that require a little bit more scrutiny for their maintenance. And the remote drop sites are already dispensed products. And so the quarterly would be appropriate in that case, and the 90 days should live with the starter packs. So we can intend to keep starter packs at 90 days and remote drop sites quarterly. 2051-1406, she inquired regarding, there's two different spots. It says for a pharmacy, essentially the PIC has to submit the waiver. And so she's just questioning, there is a location that says a licensee or pharmacist in charge related to a waiver. That is, it needs to be there because a pharmacy may not be the only one applying for a waiver. So if you are a pharmacy applying for a waiver, the PIC needs to be the one doing that, but potentially a licensee alone could be applying for a waiver. So we do have to keep those separate. So I recommend no change at this point. 2051-0520. She just inquired, this is kind of all that location where a lot of things got shuffled around. And she was just inquiring about where the 2-year requirement for maintenance of records lives now that it was pulled out and repealed, kind of repealed/edited. And so I just put in there in response that it lives in 2051-2404 for that maintenance for 2 years. So it's not that it went away, actually was in there in several locations, and we do not want the same thing in several locations. So it can live in 2404. So no recommendation for change at this point. South Dakota Pharmacists Association commentary regarding 2051-0515. This is in that pharmacy filling and refilling. So recommendation or inquiry is for this last section right here where it says for a controlled drug, the prescriber's federal registration number. Her thought was, can we put DEA registration number in there? And we already have planned to include Drug Enforcement Agency right in between federal and registration numbers. So that should tidy that problem right up. Remote drop sites, 2051-1305. So the question she proposed was, right now we have a list of staff there, and the proposal was, should it be just a staff role? And given the variety of these locations and that a lot of the locations, it's not divvied by role, who has access to the locked cabinet or the cupboard under the checkout or the locked cupboard at the hospital station, it is not appropriate to issue it by role. In a health system, I can issue access to a door or a pharmacy med room via a badge by role because that's appropriate for that. But here, a lot of the time, not all the cashiers have access to the locked cupboard. Oftentimes it's a limited number of people. So issuing it by role would not be appropriate in this case, given my visiting of places and the variety with which they are there. For example, if I wanted to give access to volunteers at a hospital, that's a role at a hospital. But how many of the volunteers are only designated to sit at the front registration desk where maybe these remote drops dispensed products are at? There's a lot of volunteers potentially across the hospital. Not all of them have access to that.
Or have been trained in
Yes, exactly. So it is appropriate to maintain a list. Now, does the list probably going to change? Yeah. But that's why we're visiting it, so that we can update those things as we need to. And a lot of these places have a relationship, very active relationship with the remote drop site. So I don't think updating that is going to be a huge hindrance. My recommendation, keep as written. Okay, so in this section, this is kind of has been brought up regarding review and storage of meds outside. I think I mentioned that I think we need to add language in regarding those meds that are in an AMDD versus not. But like I just alluded to, in the health system setting, it is appropriate to have authorized staff roles. So we do have planned to edit and remove this part of the language and include a list of authorized staff roles. So we kind of sort of flip-flopped kind of what we want to do. But here's where it's appropriate and the previous one is not. Tyler will go through that. 2051-170102. Inquiring about expanding what can be removed without pharmacist review. So the section in question, in a healthcare facility, medical staff may request in writing a defined number of drugs that may be removed without review by a pharmacist in an emergency situation. They are inquiring as to if that can be expanded. The exception can be expanded. And at this point, recommendation is to maintain the language as stated due to the complexities with changing this rule. There is additional review that would be needed because it's going to affect other components and other rules that we cannot sufficiently review right now. If there is desire to look at it, it's probably going to have to not be today. So my recommendation is to maintain as is. If we feel strongly that we don't want to address it at all, recommendation could be to remove it.
I would still push to maybe look at that at a different day.
At a different day and time, I think it would be applicable. I think there is room, but the intricacies with which we have to be able to incorporate rural versus urban functioning of those cannot be elucidated out today.
Right, and I think that rural versus urban piece, I think is our biggest concern when we're looking at that, especially for critical access hospitals, where it might not be what we in Sioux Falls determine to be an emergency situation, but pharmacy's not going to get to that order to pull out of a Pyxis and they're just going to override and pull it. So that really gives me some heartburn maybe for rural.
There are some ideas on the table as to how we can change this. We just can't do it today.
Yes.
And it does, as it reads now, it does read that there should be a list. I don't think that that has been inquired about on inspection. So it could use some specification.
Everybody's word emergency is a different.
Yes, it means a different thing. Even in our conversations in the office, it strongly means a different thing. So,
which is also why, like, is that really the best?
Yes. So, live to die another day. Last one here. Well, not quite the last one. Sorry. 2051-0515. She was inquiring again in this prescription required to dispense a drug, that section that had just a lot of revision and updating and simplification. If the full legal name needs to be there, and the rationale for that really would be that the legal name is how things like PDMP might be linked up. If you're inquiring about patient identification for a controlled substance, if your policy says I want my ID and the names don't match, are you following your policy and procedure if you hand that drug out? So we really need to hold to a legal name, but our suggestion is to remove full legal name and put it as legal first and last name so that we don't feel like the middle name has to be put in there. So Tyler will mention that as we go through there. 2051-0515-03, this is a section that previously has been discussed related to the ability for a pharmacist to issue a 30-day refill. I'm going to live in the conversation that was had earlier about that. 2051-0515-03 is in, again, that section regarding what can be on a prescription, refilling prescriptions, that area. And as we reviewed, we like to say we line up with the federal guidance, but the language in here with that word amount is not how it's stated in the federal. It actually does say quantity in the CFR. So our recommendation is to edit that word there to say quantity to match the federal language so that it is nice, explicit, and that takes care of her question there that she had. Last one is the Board of Nursing. LRC reviewed their suggestion and said it is not needed. Okay. Additional questions?
My only thought would be on that piece of looking at emergency situations and MDDs. Is there a time frame for additional discussion on that? Is like we'll need a task force when we put together? Is that the next board meeting? I don't know what the plan is to review?
I will start with a review of other statutes in other states. I think it's a great place to start. When we look at our other rural partners as to maybe what has worked for them, what they've changed recently. I live on having worked under a different expectation as to how that was handled. So looking at other states, I think will be helpful. Not that I'm not taking, or we won't, not that we wouldn't take input, we would want input, but we'll start with a review of other statute, including potentially if NABP has some. I know ISSP has some strong feelings about them, about this as well. So.
There's also CMS. CMS tends to be live and die, they will just move CMS suggestion. Because they do know that.
Yeah. Yeah. And I'm aware of some other state boards that are inquiring for some of the override language ahead of time. I recently did an inspection and the override list was required. Any auto verification orders were required. There's several of those. Some of those are being inquired by inspectors prior to inspection in states not too far from us. So.
A clarifying question on locations outside of pharmacy. Once you sell it to another facility, whether it's within your ownership structure or not, is it still yours?
No.
If
it's to a different pharmacy.
Or if it's not to a pharmacy at all, it's maybe a clinic,
no.
is maybe what I'm questioning. I just want to cross check.
Once it's sold.
No, once it's sold, it's not yours. Yes. Okay.
And maybe just to bring up a verbal comment that was made, thoughts on waivers, and individual pharmacy for every single one, or if it's appropriate to make a list of pharmacies in a chain or whatever else they do.
Okay.
Some, I guess, our initial discussion or thoughts to that would be that if a chain did that, all the PICs would have to write that. We would then address, like, essentially every facility would get, every pharmacy would get a waiver letter that if they weren't following it would be pulled. So again, because submitting policy and procedure would be one and the same.
Right.
So if that pharmacist in charge at that site said that, yes, I agree to this, so having a signature page for all of them, and then independently they would get issued. So, because otherwise if we issued one for the entire chain, if one bad person, if the heart hospital decides to do something and it's an affair waiver, then it affects you because the whole thing. So right. So we want to be very careful of
Expected to walk the line.
Be very careful about calling out the chains and stuff. Yes, they could submit it as policy and stuff would be changed, but it would be for specific sites.
So 20 pharmacies, 20 requests. Kind of
No, it could be one request. Okay. All of the you'd have to have a signature by all of the PICs. 20. Okay. Well, wow.
Sure. Just giving it
I'm going to issue an approval to every license.
But then there will be an issue to every one of them.
Okay.
Yeah.
So it does at least take maybe some of the administrative burden on the front end.
Yes. Yes.
Yes.
That's all.
Yes.
It's good another round. Just advocating for, Justin.
Thank you. Will you advocate for my having to put the patient's name on the bag before they pick it up? Or not patient, pick up
yeah,
the
we just
information?
talked about that.
So
if there's someone says that my husband's gonna pick up a prescription, you just put that name on the outside of the bag, right? It's just gotta be on the outside of the bag.
So I think I see your concern. I think my question to you is, how do you prevent bad actors who know somebody's product is sitting at a remote drop site from going to say, oh yeah, she told me to pick it up?
How do we prevent a regional pharmacy now?
Well,
I don't know.
But that's our staff though.
Well, this is something new, technically new.
Yeah.
So how are we ensuring that
So then
that's not happening?
What if they don't tell us? Then that concern is off the table. Because we can't put the name on unless they tell us potentially 3 communities away or 2 hours away. I'm driving that there. Maybe it's on the way there. Now they call and say, I'm
going to be late. Somebody's going to pick it up.
Yeah.
I don't know. I just don't think
If
it's
you tell the
operational
pharmacist,
now.
then they can tell the place to pull that out.
But now we're having them write names on it.
And
So
then-
now what if they
yeah.
write the wrong name on the packet?
Right. Or
Yeah,
if
you know,
it's after hours.
So are you cross-referencing your pickup logs then with who's appropriate to pick it up?
So like what, like a
Not
pickup
almost, same
log,
in a
would it be?
retail. I mean,
No.
Right. If
So-
my
Well, you
mom
also
wants to
have
pick up
cameras
my
at a
prescription,
retail.
she
You also
can.
have, you have security measures at a retail that are not
And it's your
at
staff.
remote drop sites.
But
And
what
so you-
security
again,
measure is there right
always
now? If
train,
my
yeah.
mom walks into the pharmacy and says, my name is Jane Lyons Labor, doesn't have anything to do with Justice Shrimp.
But
still
don't
have-
you
well-
pharmacy,
Well, if
what's at the store level though, when you go, I mean, I guess just from my past experience, I mean, we did have to, I mean, the person picking it up had to give us some identifying factor. I
Like a
mean,
date of
different
birth.
places,
I mean,
different
date of
things.
birth,
Yeah.
right, date of birth and address.
Mhm.
of the patient.
Yeah.
Has there ever been an issue?
So we do have
This
a
is coming up
process.
because there's been an issue?
At the pharmacy, we have a process of judgment and professionals that are doing it. At a gas station, you probably don't.
Right, but then I don't think putting the person's name on fixes that. What does
Well-
that fix? If I now say, you know, so-and-so is picking up that script and now the dad comes instead of the mom. Are we gonna let it go or are we gonna say we can't give it away? I don't, and I also then are we required to say who is picking up this prescription? Right.
I mean, it kind
Have
of goes back
to
though to
assign
personal
someone?
responsibility as well. I mean, this is a service that your basically pharmacy is gonna provide, I mean, for the patient, right? And I still think that patients can have some responsibility for their prescriptions. I mean, and if you would say that, hey, it's great, you know, you live in a community 20 miles away with no pharmacy. Our pharmacy does have this remote drop site service. If you want to do this, you know, this is something that we're going to require. We do want to make sure for patient safety that your prescription is picked up by you or someone that
You
is
trust,
allowed, that's trusted.
guess
So,
I just
I mean, I
don't
think you
know why
can put
we're
that on the
trying so
person.
hard if there's never been a.
I think that
I don't know what.
is the gas station attendant in the community where the individuals reside. There is nothing that's gonna stop them from giving it to mom or dad when the
Mhm.
other person's name is on.
Well, and if they
So
know
I
them, that's
think-
probably fine. But
Well, not- not-
it won't be reported, so you know.
Yeah. I think that's the, and then are we putting non-licensed professionals in a really tough spot to refuse handing a bag over to a patient? Like, I don't know
Well,
how.
besides, if we're just handwriting on there, what if you can't read that handwriting? If it's a sticky note, what if the sticky note falls off? I mean, there's no way to operationalize that electronically, it'd be impossible. So it's gonna have to be a handwritten note. I don't know how to where do you handwrite it? On the bag, on the label?
On the bag, outside of the bag, yeah, that outside of the package is what it says.
Yeah.
And I don't know what you would do to the gas station attendant that gave away the bag inappropriately when the gas station attendant isn't actually your employee. I don't, it comes into a sticky spot of what happens when inevitably it's gonna get violated or.
Well, if it was happening a lot, I get it, we need to brainstorm what's going on here, but these are super small towns that, you know, like you said, most people, they probably know them.
Can I
It's probably
ask,
their neighbor for Pete's sake. They might have a neighbor picking it up.
can I
But
ask,
everybody knows everybody.
can I ask since you bring it up, if you've had any reported issues at any of them that currently exist for yours? Not that all of them are yours, because they're not. There's lots that aren't, but I'm just curious.
Now, in our situation, we have lock boxes and the patient picks the code. And so if the patient gives the code to someone else, it's totally their response, then the patient's taking responsibility, like Melissa said.
Yeah.
So, which I understand you can't afford to do that in every gas station. But you could do it because it's electronic from a place, you know, that you could access the code. Like that's how ours is. Like the code is on, like we have an Excel spreadsheet, who assigned the code, who talked to the patient, the initials, the date they're picking up. They get a text that they have 1 day to pick this up. And then if they don't get it, it's still in there the next day. Then we decide if you're gonna leave it in there or pull it out.
Well,
But
I think
that's the patient's responsibility then.
I think it would be feasible to have to document. You
Yeah.
want, documentation is required of who picked up this prescription.
Yeah.
And it is, there is,
Which
it's in
it
there.
says that
It's
you
in
have
there.
to sign the
It's
law.
in there.
But you have to have it on the package.
But then I was even thinking too, now in our
Before-
situation, do we have to get a signature for, you know, even though they've already authorized it?
Like you can't. People signing, you know, you say, sign the law, well, you can't read any of that stuff.
Right. Well, and I'm just thinking of operationally, like, they call me and say, I'm gonna pick this up. I put it in the queue. I know it's going remote drop site, so I don't fill it until 4 PM. at 4 PM. I have no note anywhere reminding me who said they were gonna pick that up. Or, cause I can't write it on the label till the label prints.
Right.
I might not print that label for.
Till
Yeah.
it goes out there,
hours.
right?
Right.
One might probably will be you printing it.
Right,
whoever
who
was on
took the
phone.
call, who said they were, I mean, for the most part, people would probably just say they didn't tell us.
Is it instead of the name on the bag, is it and you have documentation?
Which
you wanna-
section do we have? It's 13.
I'm just looking at what it said for.
This is Eric Groskat. Can you guys hear me?
Yep, go for it.
Just speaking, obviously, we're extremely small communities where we're at with our drop sites, and it's not uncommon to have one neighborly lady, 85-year-old lady, go uptown and pick up for the next neighbor that's 85 years old. And I mean, it could bounce back and forth. It could, so quite frankly, in the city of Montrose, I could probably have 450 designated pickup people for one patient.
Right.
And it would change literally by the hour because, if Rosalie feels good at 10 a.m., she's going to go get it, but by noon, she doesn't feel well. So now she's calling Sally to go pick it up. And I mean, we can tell you what house they live in, who took them supper last night, but to have a log and to have, we'd have to go with brown paper grocery bags to fit everybody's name on it of who's authorized to pick up if that's what they're looking for.
There's a.
Yeah, and I guess just from my perspective, it's like we're trying to make sure that there's access, right? And that's the whole remote, we're trying to make sure that we have safety.
Whole reason.
And if there's no safety reason for this, I don't know why we're trying so hard to make a rule about it.
Yeah. Don't fix a problem that doesn't exist yet.
What's that? Oh, 6.
Right. Only, we've had drop sites for a very long time and not that I know of.
So I think this wording came similarly. There used to be a remote drop site policy statement.
So
and I think that's where all of this language.
I pulled
lived.
up the most recent one that I could find, and it said the identity of the patient or other person must be verified. If not personally known by the clerk, driver's license or other photo ID must be checked.
That's right.
So it still states that there was. I mean, wasn't even he checking a photo ID? I don't know how you validate that.
But if they know it, and if they know the person.
Yeah.
You have to know who's picking it up when they pick it
But
up.
I would say that it's not up anymore because it has been removed. But I would say that also, if we went with some type of language like that, it would fall in line with our expectation for identification for controlled substances. Because we don't explicitly state you have to pull an ID. It says you have to have policy and procedure to verify identity upon picking up a controlled substance. So it allows that flexibility if you know your patient. I don't have to ask for an ID, but it allows you if you don't know that person, I need to see your ID. So
I feel like the whole conversation changes if you're identifying somebody at pickup or if you're identifying who's going to be picking it up before you send it to the remote drop site. That totally changes.
And you could post a sign
So I
on
mean,
any
again, we
controlled
have
substance, but then that lets the person picking up know that that's
It's a
controlled
controlled
substance.
substance.
That's not a good.
yeah, no dice. Don't do that.
I mean, because 5 does say the identity of the patient or designated person picking up is documented in the prescription package log. So it doesn't say that it's a signature from that person. Like, does the clerk write who they handed that
Who's
to?
handed it to.
So it's legible. I mean, again, that would be kind of your policy, maybe.
So he's pulling this.
1309.
Well, and then if the process was that you
Take
validate.
a picture. There you go.
Then you gotta
Well, like,
validate ID on everybody. Then there's no differential of controlled substance from that. Like, it's some kind of
but
identification.
coming from a small town that wasn't so small. How many times did I?
So
not
could we
have a
change that
driver's
language
license?
in?
Yes, that'd be the other thing, yeah.
Right.
You can have my cell phone.
Document
You can
on the
look and see
package.
if you don't want to approve. I
Yeah, the
don't.
package log. So what needs to be,
So can we change the designated person to pick up prescriptions, name the list on the package to, the
Can
one you
we-
said about
is it necessary at all if we already have 5?
Right, so just strike
So
the.
it's strike that section
Strike
out?
that section.
I think it doesn't lose the intention of trying to ensure the right
Exactly.
person gets the right product without maybe forcing an impossible situation at 5:30 in the afternoon. Yeah, we can.
Check it out. You understand the process, and if there's an issue with the process, then that makes sense.
Well, and we do periodically stop by that. And now I think it'll be a little bit more maybe prescribed when we go on inspection to do it because it's a little bit more official. But we have, I mean, we do periodically stop now anyway, just to be like, where's this located? What's your process? Is it clean?
So just strike that last.
I would, strike that if a
second sentence on
designated
there.
person section.
And if it becomes an issue, then we readdress it.
Yeah, yeah.
You want to let people help.
Yeah. Okay.
Where are we at?
Yes.
You're at the end.
Jeremy, did you feel like all of your verbal comments were addressed? Because you did have several. So I just want to make sure that I had wrote things down as you talked.
I think so. A lot of them were just about, again, some specificity, some of those pieces. The only one that I don't know, I think we could talk about, because you go through Ian's comments on 1518. I think they all have.
Yeah. Good.
Yes.
Okay.
Perfect.
Okay.
Awesome.
I have one.
Oh.
Only because it's fun for me to find stuff that LRC missed.
Oh.
And it's very, very trivial. But on my page 33, under 2051-1305-03, under number 4, requires a period at the end of the
Oh, nice.
Nice.
Way to go.
No, it's not even in there.
Make sure that's in the addendum, Tyler.
I will.
Tyler, would you like to summarize? And do you want these bullet points to be handled individually or as one motion?
We can summarize, and if we agree, then we can, then you guys can vote as well. Okay, so to summarize, I think what we're going to do is Jenna will pull up the Word document and we'll make the changes as we go to make it official, like we were going to do.
You can't see it, but I can.
Awesome. If you want to, you had something on there highlighted that you wanted more discussion. Which one of your slides on a point?
Yes.
It was yellow.
Let me go back. I will find that quickly. For 13066. Thank you, Jeremy. I'm getting there. I'm just pulling up on mine and then I'll bring it over to the big screen here. So we can make an edit on the fly if we want to. Sorry, give me a minute. Yes.
All right.
Okay, I'm gonna pull it up here. Okay, so this section right here. See, I gotta find my little mark so you know where we're at. This is a big thing. Off-site medication storage. So this is kind of the quote unquote starter pack section. So these are things stored not within a pharmacy. It could be a clinic. It's most often a clinic, I would say. And in here it says pharmacy staff must conduct on-site inspection at the off-site location. This is heartburn for me a little bit because pharmacy staff could include a clerk, but the actions that we require at that inspection include policy and procedure review, log, expiration check, dispensing check. That would be outside of a clerk's job. It also potentially could put like a pharmacy delivery driver in the pharmacy staff language, but I'm not sure if pharmacy technician can go as well because we don't have immediate supervision, which is what is defined as a pharmacy technician. So this was one of the questions that was brought up in the written comments. Should this just say pharmacist must conduct an on-site inspection at these locations every 90 days? I hesitate because I generally, again, a little bit more rural location. Can the pharmacist go do that check?
So these would be stored. Keep in mind the places these may be stored. This could be an e-kit at the nursing home. You have a consultant pharmacist every 30 days. Assisted living.
Can
Is that 30 days or 90 days? I can't remember. A pharmacist is already there doing chart review. Another place that these might live is in a clinic that's a ways away. For instance, starter packs, just again, because Jess is in the room using Mitchell versus well, not Plankton anymore because there's telepharmacy, but there is one other town.
Clear Lake and Estelline.
Clear Lake
and Estelline, like Preston. Yeah.
So there's the clinic has a few starter pack medications that are those. So is it uncalled for that a pharmacist go every 90 days to review those, or what are the thoughts? You know, those are the places that these are.
Mm-hmm.
So I have two things. So could a pharmacist designate? Because a pharmacist certainly knows which staff person can do this. And does it have to be every 90 days or could it be?
So for this one, it's every 90 days. Right
Well,
now.
yeah, this is, but would it?
Well, for outdate purposes and stuff like that. Like,
I think that it warrants a little more scrutiny when this becomes like you're sending meds home to patients and you want to make sure things are tidy. And I don't know that shifting to quarterly is appropriate. I mean, maybe even every 60 days is more appropriate, but I feel like we landed happily with every 3 months and you can do outdates then and you can swap out product then.
Maybe you could meet in the middle of those two ideas and say the pharmacist in charge or pharmacist that oversees the remote drop site goes every, I don't know, quarter, 6 months, but a designated staff member goes every 90 days. So if all you're doing is checking for outdate, you could send a tech to go do that. But if you're reviewing the policies and procedures, which I can't imagine you every 90 days, you could split.
Yeah, because how often
Because
do
you
they
could say or
change?
designated, right. You
Could
could
even
say-
say upon change, like for a policy and procedure.
I think for me, the bigger issue when we really drill down to what we're allowed to do, can you designate a technician to do a function outside of your immediate supervision when their definition is under immediate supervision of a pharmacist? Yes. And I think the minute we say that that's appropriate in this case, you start bending rules in other instances that we don't want
I
bent.
mean, I would definitely say it's possible to get a pharmacist there every day. It obviously dips into the profitability. Those are profitable anyways.
Mhm. Right.
Now, like Aberdeen, we'll send a pharmacist, we're gonna pay them their mileage, we're gonna pay them for their time on the road,
Yeah.
it's expensive to pay a pharmacist to drive a couple hours, but.
For starter packs. Yeah.
Maybe another caveat of this is in our current world of technology and having telepharmacy activities and rules surrounding that, does it have to be an on-site inspection on an every quarter basis? I mean, I can see the benefit of a pharmacist going on-site sometimes, but does that have to be every quarter that someone steps foot in place?
Well, can't you keep a perpetual inventory of what's
Right.
there? So you know when you have to go.
Yeah.
You know, you're not gonna have to go every 90 days if nothing's going to.
But I mean, if you want to check those outdates or make sure that like the place is clean, I mean, can we get a picture?
Could you
like I said, do you have to have on site or do you just say conduct an inspection?
Yeah, I mean, valid.
You know,
That's why I wonder about
because
that
you could take
on-site.
you could have somebody there take a phone around and say, okay, show me this and show me this and show me this and.
I question
How would you
our
put that in?
technology.
Is that an operational waiver, folks?
I was gonna
Like,
say, like, are we just doing a waiver right now?
I'm just telling you, is it an operational waiver? I mean, here's where you live, because we all have 1,000 ideas right now. Nobody can land.
Like the best is
Nobody
90.
feels like it.
Have a
Here's an
waiver for
operational
6
waiver.
months. If you're not following it in 6 months. find
Pharmacist,
something
put
down.
pharmacist in there and let it be an operational waiver.
Yeah.
Let
There we
somebody
go.
see
That's
what the
perfect
best
idea,
process is.
Because every situation is so different.
There we go.
And
there might be
who
two things in there, and then they.
and who owns them, because sometimes we have a pharmacist lives over here, the pharmacy's over here, and they drive through the place that the starter packs are. So then that works for them. Stop by on the way, I can check it out, I'm good to go. That doesn't work in every scenario though.
So leave it the way it is and get an
no,
operational.
I would change it to pharmacist so that we do not have the issue of potentially functioning in our registration
Right.
outside of what's appropriate.
So pharmacist and then.
Look at all these brains coming together in this room, folks.
So late.
And this is only starter packs.
This is starter packs, yes,
And then the remote drop sites.
quarterly. And there's nothing to say whoever's delivering to your remote drop site can't do a spot check to make sure it's not got mice in the cupboard. You know. Okay, you're going through edits. Do you have page numbers to give me so we can
I do.
expedite this for us
Yes.
here?
Are you ready? Page 3.
Oh God. I can't just put page 3 in the Microsoft Word document.
So, but we should save that one for the end, because if I remove it, it's going to generate page numbers. We're going to remove page 3 because that's the LRC.
Oh, if I can put a comment in, I'm not removing, I'm just
okay.
putting a comment.
Remove page 3.
Oh, no, 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 no. No, 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 no. Just hold on. I'll get there. You start talking, I'll work it out.
That's it, just because the LRC concern. We have
Yep,
to
move on to the
remove
next
page
one. I'll
3.
put that in.
Well,
The only comment.
page 11.
Okay, page 1.
Subsection 1.
Okay. I'm going,
Wait,
I'm
is
going.
quarterly every 90 days? Sorry.
Ish.
In my note, I said
Yeah.
remote drop sites quarterly.
Yeah.
Starter packs every 90 days. And my admin said, that's pretty much every 90 days.
Oh my gosh.
Exactly what I was sitting here.
That
thinking,
is
like,
so
have I,
crazy.
like,
How
lost my
I've looked
mind?
at it 1,000 times and never like.
Well, see, like, you can think of this. But like 90 days, you could hash down closer to like, okay, 90 days, not quarterly. You could be 1 month apart. Oh, I forgot this quarter, and then I'm gonna get ahead this quarter, so I go fishing the next 2 months. I don't know.
So quarterly you could do between
It's not the
January
intent, but
and the end of March. So you got January to the end of March and you got April to the end of June.
I don't think general.
So anytime in that quarter you can do it.
see, that's
So if you
why
do
I'm
April
like,
till the end
yeah.
of June and you do it May.
I can't wait to
30th, and then
describe
you
this
do
to
it
people on
June
inspection.
2nd,
Like,
we're
oh, your remote
okay.
job site and the
Yeah.
starter packs. So
Let's
here's
go
that 90 days,
Yeah.
you're your quarterly over here.
2 hours.
Yeah.
First.
We all were right on board with you. You know, the way
I
you
was-
said it.
was I
You're convincing me.
I tried.
I was
tried.
Kind of like,
It's like, wait a
kind of
minute,
like,
my
well.
admin was like, that doesn't help me for staffing.
So-
to get this done.
All right, so subsection 1, the full legal name. So we would add the words first and last after legal and before name.
Did I do it right?
Yeah.
Okay.
On page 11, subsection 4, change the word signature to name. And on subsection 5, after federal and before registration as drug enforcement agency.
It's actually Drug Enforcement
Or
Administration.
administration.
See when it comes in.
It's D.
It's the DEA, but yeah, I just.
Okay.
Administration.
Page 14. Under remove the word amount and add the word quantity under Schedule 3.
Here.
Yes. On page 30.
Whoa. Pharmacist.
Yep. There's section 6. Yeah, that one already. Changed to front. Page 33, subsection 4. Add,
remove that section.
oh yeah, that's page 34. That's the next one.
Well, I did that one for you.
Go to 33, subsection 4. We got the most important fix on this one. We need a period after cabinet.
Cabinet.
You can just add a period in.
Where's it at?
On,
End of
right
cabinet.
there.
It needs a comment. Tom Nelson buried it
Page 45, subsection 4.
Sorry, folks.
Remove names of facility employees.
Sorry.
And change to a list of authorized staff roles.
On here, were we also looking at adding in language regarding if it's not in an AMDD or not?
I mean, those should still in some way, shape, or form be reviewed at least monthly, right? I mean, you're most likely touching them. I mean, the machine, yeah.
But like, what do you then constitute a record of monthly checks?
That you filled it and anything, right? I don't know.
What does that mean to you?
Yeah, right, that's open to interpretation. I don't want to re-document this. No.
And I don't want you to
may not check
document.
I mean, you're not gonna touch every medication.
Right.
No.
It's an advice on a monthly basis.
What is the record of monthly checks accomplishing? Is it purely outdates?
It would be to
Tampered
check
with,
outdates, tampering,
stored
yeah, if
properly.
products is in the right location, if it's been opened, product integrity, basically looking, putting eyes on your product.
I would think that an AMDD is only going to allow you to access the product or the pocket that you are needing to access, which then will probably prompt refill, and the AMDD also automatically tracks expiration dates as well. I would think the AMDD itself would be exempt because inherently you're already doing that. Does the AMDD section of the rules stand alone a little bit? If we would exempt AMDDs from this portion, is it addressed in the other?
Also says policy employees, so that one's affected.
That would be fine. Because you're allowed
So
within
you're
the
in a
facility.
hospital that's
Mhm.
already based,
Yep. Like that, it's appropriately in there already, yeah.
Had to prove I was still on the phone.
You're good. Because inherently an AMDD does all of those on there, outside of 3 technically. Like in its own functioning.
And the AMDD itself print a monthly report?
I mean, yeah.
Practicality's sake, it would not be valuable.
Yeah.
Not, no.
So how would
But it
you?
could be readily retrievable anytime you want.
Do you think I'm gonna look at it?
I hope not.
I mean, of all the things to look at,
So do we put like outside of it?
yeah, do you put in location other than pharmacy, comma, outside of an AMDD? I think LRC is gonna have a problem with the words outside, excluding, maybe that's excluding those stored in, nice work. Excluding those stored in.
Those stored in automation. I don't know if there is a world where there's a med car that is physically outside of the pharmacy. I guess if we expand any more at Sanford, I'm going to have to put it outside the pharmacy. But is it excluding automation? Medications kept in automation?
AMDD is what we have in our thing though, isn't it?
We'd
We'd have to put AMDD because that's what's,
We'll reference to 17.
yeah.
How about kitchen trays that are tracked by software, that we have all that same information through.
You're talking about kit check, right?
Yeah, oh yeah. I mean, that's what you keep the same information. We know location, we know list of drugs, we know expirations, you know.
I was thinking the same thing, Ryan, for crash carts or through kit check. So does that suffice?
So it's more about the integrity.
Could you put a disclaimer that says unless automation?
Or you can have an operational waiver.
Get ready for those.
Is there regulation in the hospital section for the DOH that requires monthly checks on all meds? Because that would be the hard stop. That's the other thing that could be in there. So if they come, it's not even CMS, it's like hospital,
Well,
does
that's
it
who
say,
they do.
well, yeah, but is there regulation that says they have to have proof of checks? Granted, I don't know if that would be allowed non-pharmacy staff to do those checks in that setting.
Typically, it's keeping it pretty vague of there's a process in place to ensure integrity of product and appropriate dating on medications. I don't even know that it specifies to the T who's doing the check or how often. It's just, we have to have a process.
Because if we say automation, that could be pretty broad.
I think we keep it to the AMDD right now because we define an AMDD. Because if we say automation, we're not defining automation anywhere. And so that's too vague.
Yes. Do you, for your kit checks, do you put eyes on them if they've never been opened?
In a month.
Yes. You only put eyes on them if they've been opened. So how do you know if they're opened or not? Yeah, but I mean, so if somebody pops the tag.
Somebody puts eyes on them, so our crash staff that are on our units.
Yes.
Nursing staff looks at them every 30 days, has a full check, checks all the drawers and then reseals them.
Do they look at your drugs?
They look at the tray. Make sure it's sealed.
Yeah. Or they look at the tag every shift to validate.
It does say the expiration on the tray, so they're checking that to double check, which we already made.
I would say, so in this theory though, like they're checking integrity of the pack. Are they checking just integrity of the packaging? Or are they checking the product?
The expiration date on the tray though is.
But what I'm saying is you have a bag, right?
Yep.
If your bag is open, that's integrity of the tray versus like the checking the product individually. Right.
The integrity.
The kit that is still together.
But they're not looking at it.
No,
Because
that,
the
yeah.
bag is sealed.
They don't care. You checked it.
Yeah.
So I was wondering if you just change pharmacy employee then, take out pharmacy.
But it's not even that, it's like nursing that.
No, but
checks
that's what I
are-
mean though, because it's a facility. Because the line 4 says facility employee.
Mm-hmm.
So the line 3 says pharmacy employee.
A couple of the things that we've ran into is in.
I have found too many instances within the last
And
6 to 9 months where I found product not managed by pharmacy, even though it's drugs, that's outdated, expired, stored inappropriately, open, has special notes on it, then it can be used even though it's expired. Product people didn't know were in places. That's why pharmacy employee is important. So we are a little bit balancing maybe rural expectations here too with your heavy ability to automate, which doesn't exist 30 minutes outside of Sioux Falls.
Does that fall
So
into a plan of correction where you'd say, well, if your process isn't working because you're using staff that maybe aren't
doing what they
taking
should.
full ownership of this, then the next step is they've got to create a new process that maybe the next step is they've got to have pharmacy employees do it. But if your process is working, then you don't have pharmacy employees.
So if it's,
I want to encourage,
if it's.
I
not
think it's
agreeable-
important that pharmacy be involved in med management no matter where the hospital is located. And the minute you hand that off to someone else, pharmacy becomes less important in that setting, irrespective of if you can automate or not.
To make it more strict, like if we have in rule that it can be hospital staff, whatever. Basically, the process you're describing is we would have to do the inspection, corrective action, hopefully they would voluntarily do it. Worst case would be we would have to file a complaint. We would then have to go through the discipline process. We'd have to put that facility on probation and then have this further restriction. And so to do all of that versus have this and then, okay, you guys have the kit check, and you guys check them. I mean, some of your carts are probably used daily. So that's different than the smaller places.
So if you're,
and the
if
smaller
you-
places
well,
don't have.
and
kit
if your cart is used daily and it's turned over within the last month, does that qualify for having been a monthly check?
checks, I would say.
You could
that-
argue that, I think, with me. I say me, but that's simply because I come and I look at your stuff. So
Yeah.
it is going to be me.
Yeah, but that makes sense because
You
if
know
they
what I
go back
mean?
to you, right?
I mean, you could tell me I've checked it within the last month because we've turned it over
Right.
within the last month.
But
But some of this is where meds get in a cupboard and nobody looks at them for 3 or 4 years, and there they sit. And then I roll in and I say, open the cupboard, and there we pull all the stuff out.
So that sounds like a little bit of a pharmacy expectation and accountability component. I mean, I hear you and I get it. I think the challenge is whether I list that there's a lidocaine in the OBGYN room cupboard, or I list out exactly that there are contents of the crash cart and a member of my team goes and looks at that every single month. I think the inherent issue is that the expectation is that it is pharmacy's onus to develop a process that appropriately and safely monitors medication storage, integrity, and expiration throughout the entire facility. Like, I think that's the little bit of to your point, Jenna, it's
That
your
is my-
expectation. I don't know that these expectations accomplish that, because I can say checklist, sure, I went to all these locations and there's still an expired vial in the cabinet. I don't know that it, outside of a statement of the expectation is that pharmacy will develop and monitor processes for storage throughout the facility. I don't know that all of it fixes it.
What I feel like sometimes if we just make statement of expectation, then nobody knows what the expectation is, and it's on myself, Carol, or Lee to tell them what the expectation is. And I'm not going to live in the world where my expectation and Lee's expectation is not the same, and we swap, and then we have different inspections. So we do need to have some semblance of what the expectation is for that integrity person.
If we look at what we struck to change this, previously it was drugs and medications located in areas of a facility other than the pharmacy must be under the general supervision of a pharmacist in charge. Probably every hospital, we could nitpick that one to make everybody in violation.
Absolutely.
So really we've toned it kind of down. It looks like more, but really we're asking for you knowing what drugs are where in your facility. And then a check of those, it doesn't have, I mean, again, processes, you're probably already doing these
I
things.
think it's actually delineating what the expectation is better than what the previous was.
Right.
There's less subjectivity into what your general supervision of the pharmacist in charge is, because that's pretty subjective. If I ask, well, who's in charge? Oh, well, I know they do it. But then
How do you know?
how do you know they do it? Are you checking behind them? Are you checking to make sure they're doing it? Are you spot checking? Like, what is the expectation? Currently, there isn't anything outlined, and we've outlined an expectation that I feel like is meetable. Now we have things like technology that slide in there that, how does that work? Maybe we have to work through that.
But we also have to remember the little guys.
That's what this protects is your little guys needing to ensure that there's a pharmacist involved in the operation with their drugs.
Because if
They
everybody,
have to have the bandwidth to do it.
if
too.
everybody
But
has
I'm not
kit
in this
check,
part, but I'm
right.
like, pharmacy
The-
staff shortages are real.
True, but
Very real.
If everybody,
And it's,
I
I'm
don't
just-
know in
I
the
was
in
monthly
the span of
something.
operations that I can see, and this is, I mean, vulnerably at the med center, I don't think I stand a chance to hit this on the nose, much less. I would probably stand a better chance at a smaller hospital than I do at a med center. I fear that a guidance statement I think would be really helpful, because to your point, I think there are different ways to monitor different systems and cabinets and crash carts and technology and all of the things. I've got, the more I sit on it, I've got some concern that we'll be able to meet it in a way that is not just administratively adding extra documentation and work.
Can I just inquire about what our expectation to the board would be for a record of monthly checks? What does a monthly check look like?
First, why does it have to be monthly?
Because expiration dates.
We said quarterly at the other one.
And
Yeah.
oh
but
my
if
gosh.
If they know it's in there.
Oh my gosh. Can't handle
Or
it.
90 days or whatever.
Can't handle it. Can't handle it.
It wouldn't quarterly kind of save a lot of issues with this? As opposed to monthly or not?
Well, to me, if
Are
they
you
know
okay
it's in
if-
there from a printout, which I don't deal with these either, so I don't have an idea. But to me, if they know it's in there according to the expiration date, that you could get that through technology, then it shouldn't have to be monthly. Because if there's an expired item, then you're gonna have to go change that out.
Different places in the hospital.
So I mean, I don't know, but
because see, like, I just think like Avera and Sanford and everybody, like, on the floor, all of your meds, there's no reason to not be in an AMD. They're already in the places, like, versus the small places where they might not have an AMDD in the ER. So therefore they have a cabinet of medications. So that's, I mean, kind of also
That is
food
a
for
scenario
thought.
that is real. I think of the place off the top of my head, including controlled substances that are not in one.
I think there's just unique things like code cards and things that aren't in an AMD that you have to go and you have to get leverage technician support to go and check these routinely when nursing staff have a process, and frankly, they do a really good job at it.
And I can't tell you last time we've even looked at our tray and our ECP card.
I mean,
well, should
this
it
is
be a
on
policy?
nursing checklist that they review.
What can I enforce on a policy? I mean, that's
Well,
a
would you
policy is
list-
not enforceable. It's simply a guidance. So if somebody's outside of policy,
Right.
can I give them a deficiency on an inspection or not?
Jenna, what prevents you from issuing a citation or what have you on the fact that the facility does not have a defined process for monitoring access, outdates, integrity, etc.?
I think.
Or is
the
that still
greater-
too vague?
I think the greater issue is that you can have the policy you have in place, whatever it is, but when everybody has a policy and I still find stuff
Then
not in
everybody's-
line with it, then to me, the policy is no longer just having a policy is sufficient. I don't want to find expired meds hiding in cupboards all over places. And I don't want pharmacists to look at me as we're going through the cupboard and look at me and go, I didn't know that was there. At least in this case, there's an expectation and need that the pharmacy department would have to say, I need to know if you put meds in a cupboard. Oh, it's checked by nursing staff. We take care of it. Oh, it's checked by CRNAs. They take care of it. And then we walk in there and there's expired products, there's stuff out of packages, there's no expiration dates, like, so then they go, well, they're in charge of it. Well, but you're the pharmacist. So like, and then well, this is their space, so you can't go in there to the pharmacist as well. The drugs are in there. They're responsible for the drugs. So at least in this case, I feel like there's something outlined. And if we look at what monthly checks mean, to me, maybe that's where, if we're looking at like, can you show me you've checked something within the last month on your cart, that it's been accessed within the last month? Does that constitute a monthly check? Maybe. You can show it, right? You have like an e-kit, like you have a tray that's been sent there, right? So is that conducive to a monthly check versus like a cupboard hiding in cardiac rehab that's locked and 3 people have a key? And I've never looked in there. Well, then let's go look in there. What's in there? And we find that there's lidocaine that's pulled from the ER, some aspirin, a heparin flush. Like,
It's outdated.
That's all outdated then. And not that you are looking at going after the pharmacist, because I say going after, that's not what I mean. It's not that you're looking at penalizing the pharmacist. You are allowing them to be in charge of the drugs in their facility, which is their job. So
I hear what
more
you're asking. Truthfully, I'm going to share that even with this, we're still going to find drugs hiding holding cabinets. Like I understand. I think reality and putting action that is actionable and effective to what we're trying to achieve. I fear that even the bullet points here are not going to prevent those things.
Yeah.
So then we just leave this as it is.
Yeah.
Because then you have some guidance.
Yeah. And I don't think if I go on an inspection and we like find a couple outdates, I generally, if we find a couple outdates across all of McKinnon or across all of Sanford, we found one outdate. Okay. Make notation, verify. I'm not too upset about it. When I go and we start pulling 20 bags of IV fluids out of a cupboard that the pharmacist didn't know was there, is supposed to be checked by somebody, but there's another person involved and they're supposed to be responsible, then there's an issue. And that still occurs.
That to me feels like a facility process issue versus an everybody issue, I guess.
Well, technically it's drugs, it has an NDC.
Only.
Yep.
Because that's a whole nother thing. We work those very differently outside of that,
So does
this, now this even becomes that's a
Even
bigger
things that are
issue.
required under DSCSA, so that too.
Yeah, because if there's an expired drug product,
It's a drug. It's
the drug product.
It's only on it. It's a drug. It's
It's a
into
drug
the body
product.
to modify the therapeutic need of a patient or whatever. The drug.
So does this verbiage right now work for what you need, or do you feel like
like I said, the only piece I feel like we can exclude that broadly covers rural and big facilities that we have would be excluding those AMDD systems because they are already doing this. I don't feel like I can't put the word automation or technology in it because that's not all encompassing.
Right.
And AMDD is defined in our law and rule, so I can tell you exactly what that is.
So I think we do that
And leave it.
and leave it.
Yeah.
And do waivers if you need to.
Yeah, or I think
Because we want to move towards that the board can go anywhere that there is a
Thank
drug.
you. Thank you. That's the other thing.
And that's the thing, and we don't have that right now, so we need to get there, so we can't change this to make it more lenient, because we need, because then it's gonna be your discretion.
Yeah.
Okay, so we move forward with ADD. And then-
Can we excluding those in an
So
AMDD?
if we like after pharmacy, location other than pharmacy, yeah, right there, we put outside of an automated mechanical distribution device, comma. The pharmacist in charge of maintaining the following information.
Okay.
Would this include?
Yep.
IV contrast.
Only.
RX only is the defining black and white line.
Yeah, they call it RX, but RX only on this package.
I feel like that's one that walks the line. Correct me if I'm wrong.
It is.
It walks the line.
Physiology.
Yeah, it walks the line, depending on where you are and how it's handled.
I can't remember if the package.
I can't remember,
We
but
don't-
I remember it.
It always
Some
bounces.
says
I
something
mean,
and some don't.
It's the same with fluid and materials.
But here's-
this gets really,
But the
really fast.
the other thing that we have is the ability to come back if there is a significant issue and revisit it if we need to. But there's been enough issues that have been found in the last 6 to 9 months that warrant addressing this in some capacity. And moving forward, as the board has prescribed to us that we need to not only just be looking at drugs in the pharmacy, we are interested potentially in drugs stored in any location. And so if we don't move forward with ensuring drugs in the places that are licensed with us are handled appropriately, then we're not gonna be able to move forward in those settings either. So,
This is
okay. I don't know.
44.
60 days is
45.
What?
Possibility could be meeting in the last 60 days, give us 2 months and two checks. I mean, think of the scope of what we're talking about, which is fluids. and
Yeah, well,
potentially
but
contrast.
here's the question. Do you have fluids and contrast that don't get looked at within the month?
Yeah.
Like
sure.
there's
Oh,
like
yeah.
like give me an
Units are
example
able
so
to-
I understand.
I mean, even for our ECT like medication
Mhm.
tray, that outdates. That's how I change that out.
Yeah.
Is we have not had a medical emergency in ECT in a long time, and so I don't touch that on
Okay.
a monthly basis. I don't think I even touch it on like an every 6 month basis because our drugs in there they give us really good dating over McKenna because they know what it's the tray.
Just
Nursing
outsider's
units that-
perspective, where is Ashley today? It's just nice when the board has,
She's
Ashley, are you on? I just want to hear the board's perspective from the hospital side because it's not represented right now. Are you there,
Can
Ashley?
you, yeah, I'm here. Can you clearly,
Here,
or
Carol.
I can't quite hear you super clearly. Can you repeat your question?
Well, I was just being a pain in everyone's butt and saying the reason we have different practice settings represented on the board are for exactly this, so that we can hear. It sounds like the hospital systems are the ones saying this is going to be pretty difficult. So since you're the board representation for the hospital,
So I feel like I think pharmacy and like if I am the pick over a pharmacy and there are medications in my facility and under my purview that are outside of the pharmacy, and I know that they're outside of the pharmacy, that is my responsibility to make sure that they are kept, as everybody has said, within date, that the integrity is there. So I don't think it's unreasonable to have a process in place to where, especially by rule, as it's listed here, to work to have some type of monthly check. I mean, that's the thing that I think is really weird that everybody's getting all angsty about, is because I feel like this is already our practice. So I don't know why we're upset when we're putting it down in the rule that we would want to be in charge of this process.
I would suggest it's already a practice, but it's not owned by, it's not owned exclusively by pharmacy, partnering with our units.
No,
to-
but aren't you there as the resource to ensure that they are doing it correctly? I agree with you. Contrast is not in my privy. However, I am the content expert on how to make sure that contrast is sitting in my facility correctly.
But your team or your pharmacy employees doing the actual record of monthly checks here is what this is describing.
Oh, actually, yes, we are in our facility I just cross-checked. So in our imaging department, our pharmacy tech. So yes, the imaging team is responsible for it in their own right. However, a member of my pharmacy team is also going behind them and cross-checking that they have everything in order.
That's pretty impressive.
Is it the monthly that's causing headache? Or the whole thing?
Yeah, every month we look at everything.
I understand the intent, and I think there's value there. I think it's going to be a big lift, a big change, and so I think monthly is going to be difficult to find our resources and adapt to reviewing all the locations where we have contrast, we have fluids, where nursing units procure their own fluids and
Now, Ryan, I do admit that when it comes to the fluids, that is managed by our supply chain. And so in that regard, we are not in their storeroom looking, like down in the main storeroom for supply chain, but we do review, the locations on the floor where they are not, I guess, under the normal eye of that group.
Hey, Ashley, this is Tyler. Can I just ask a quick cross check? So you said member of your team, is that a pharmacist, technician, designee? Who is that person?
That would be the pharmacy technician is going. Now, anything that needs to be exchanged or that gets brought back or getting taken down or whatever, even, that is reviewed by a pharmacist. And then we have like an inventory checklist that is then reviewed by a pharmacist when the pharm tech completes the inventory inspection for that area. So that's how we have done our oversight over the process. Obviously there's different ways to skin the cat here, right? Like this is how we chose to do it. That's not the only way that you could, maintain success and compliance. Now, maybe it isn't necessarily monthly as listed, but as there are medicines in our facility, I'm surprised we don't want to go and look in those spaces and places when, even Allie said, we know that there are medications and things that live in areas that hide from us, and I feel like when we are out and about in our hospitals or clinic spaces, like it gives us the opportunity to then go look for things that might be erroneous. But if we have no cadence, and maybe monthly isn't the right cadence, like whatever, but if we don't have any want and need to go and look at that stuff, are we really doing right by, I guess, our jobs as pharmacists or pharmacists in charge, I guess?
But
So again,
as a philosophy, though, how do you guard against the drift of, I didn't even realize that there were medications in that cupboard?
Well, I think that is why you're out and about looking, right? Like you don't know all the crazy things that people are going to do, but that's why you need to be out there looking.
At the critical access facilities, it's done almost monthly because they don't want to expire things 3 months ahead of time.
Like I don't think we're putting it out there to try to catch every single thing that may or may not happen, but I think it's out there saying that there has to be some ownership, especially if I'm the one dispensing these medicines out of my pharmacy.
Yeah, no, I don't disagree at all. It's
hard with fluids.
Ashley, that's where I think we're going.
Is it like a record, a check?
I think it feels a little bit, and you're right, there's more than one way to skin a cat. I think if we're putting it in rule like this, then we're giving only one way to skin the cat. And I think that handcuffs us a little bit.
Whatever, and if they want to be more restrictive. Like
So if you put down quarterly and then the facility, at least quarterly.
What if we did at least?
So whatever chatter's happening in the boardroom, I literally cannot hear any of it. It is garbled.
All right, well, this is Tom, and I'm gonna bring this to a head or a close at this point. The discussion has been excellent, and I've learned a lot. So a lot of it's still over my head, and I hope you appreciate that. But at this point, we do need to bring this to a close. And how are we going to handle this?
I'm going to recommend we change monthly to at least quarterly. Do you guys have any
Tyler?
Thoughts on this? And that makes it easier on facility. And if you have, stuff that's outdating in that quarter, coming up, you can pull that stuff or designate this to be used first or whatever. But at least quarterly it's getting done, it's prescribed, it's expected. And, if facilities want to do more often, they can certainly have policies to do it more often if that's what's, going to be relevant for their facility. But I would say
do you feel like it strikes a balance given the conversation that has occurred?
Yeah, it takes some of the pressure off of doing it monthly, but it does put pressure on doing it. So
I think quarterly sounds reasonable to have as a minimum standard.
Is this a motion? So we need a second?
We're modifying it right now.
Yeah, modify
So on
that.
page 45,
That's a good
change to quarterly.
Because we have to have something there. And so this will be good.
that way it doesn't put a 90 days or 60 days on it, quarterly.
Well, then, what I like about
Given our other conversation.
No, what I like about quarterly though, so you guys have all these places okay, well, you do some in January, some in February, some in March. You got 3 months to cover all of your. I mean, quarterly is good because you don't. Where monthly is a little rough because you got to hit everything every. So I like the quarterly with the.
And it would allow, to coincide with your full pharmacy inventory and hit one of your quarters versus
Right.
having to hit that 3
Right.
times at the
Right.
time you do a full,
Yes.
like, go out and you count every Pyxis machine and you do all those things. So it's like 1 time a year out of the 4 is already taken care of.
Right.
With your
Right.
inventory.
Yes. No, that's good.
Right. So page 45, I think we're good. Page 40, go back up to 41. I missed one. There's only 2 left.
We're gonna be okay. I appreciate the rousing conversation. It was good though. It really was good. Like.
Page 41.
I'm going.
Okay. It
Oh.
is recommended to read, the board shall review each waiver at least annually upon notification by the State Board of Pharmacy, any
Slow down.
adverse issue, well, it's there,
Okay.
I was just adding.
Okay.
Any adverse issue resulting from a waiver. We are going to add right there, the board shall investigate the reported issue, period. Upon investigation, comma, if the board determines the requirements in squigglies
Yeah, just tell me what.
2051-1405 are not upheld. And then it'll continue on to the board shall notify the licensee or pharmacist in charge in writing that the waiver is suspended pending full review.
It's in there.
Awesome.
Fun.
And lastly, on page 68, we're going to remove due to LRC's statute concerns. That is all of the recommendation. Those into a motion.
No, I
Thank you.
motion that we-
It's all there. Thank you all for the discussion, the concern, and the passion that you all have for your work. Is appreciated, especially for those of us that take it.
Did you motion?
He was getting ready to when I interrupted.
Okay.
I would
Yeah.
entertain a motion to approve the rules package as presented.
I make the motion to accept the rules package as revised.
Second.
And Ashley on there.
Yeah.
Motion by
Jane.
Jane and second by Ashley to approve the rules package. Is there discussion on the motion? Hearing none, is there objection to the motion? Hearing none, the motion is carried. Tyler, Jenna, anything else to come before the board? This is the single agenda item for this meeting.
Rick? So other than just the next steps to this will be, these rules will be presented to the Interim Rules Review Committee in Pier on July 14th. If the rules process is deemed complete for this set of rules by the Interim Rules Review Committee, the rules will become provisionally final on or around August 3rd, which is 20 days after they would be filed with the Secretary of State.
Thank you. Thank you all. With that, I would entertain a motion to adjourn.
So moved.
Seconded.
Motion by Sherry, second by Shane to adjourn. In favor? Is there objection to the motion? Hearing none, we are.